percentage of the 90 plus will go up from below 1% to 3.06%. In terms of percentages, they might not be very high, but in terms of numbers, when you think of the total numbers in this population, it becomes quite a lot. And then 48.2% of the elderly are women. And feminization of old age is again a fresh set of problems. 58% of these elderly women are either widows or they have been divorced. 75% of India's elderly live in rural areas and 1/3 live below the poverty line. So these are additional problems for us. 5.5 crore go to sleep on an empty stomach every night, just about the population of UK. And an estimated 50 lakhs live alone, more than the total population of Australia. In 2040, within 30 years, the great, not even for 30 years now, it's just, how many, 25. The grey population in India will double. So that's why we are very concerned. I talked about feminization of aging because elderly women or old women have lots more problems than old men. In terms of numbers, you know, there's a saying that women always live longer, though they are deprived for so many things, yet we live longer because of our constitutional, perhaps. There are so many things, so many issues, so many theories behind that. So the numbers of old women in this country are going to increase. Their morbidity patterns are different. They have additional morbidities, special morbidities in the female population. And this population, which is becoming old, have never really been like you and me. They have never earned themselves a fat sum to put away as social security for old age. So mostly they are poor. They are dependent on others for whatever they have. So that's again a huge problem in terms of healthcare and public health. These are some of the world's oldest countries. You know, Japan has the highest number of old people, followed by Italy. We're not there yet, but we are arriving at a rapid pace. Now, I'm sure this will be deliberated upon in greater detail, so I will just touch upon this. What we call the group 2 deaths, this occurs more amongst this population which we are now facing in this country. Digestive illnesses, respiratory illnesses, cancers, CPDs, all these group 2 deaths and non-communicable diseases, as you can see. All these types of deaths, if you see from this graph, population aging contributes largely to this category of deaths, the group 2 deaths. So the aging population is suffering more, and more vice versa as well. The morbidities and mortalities due to these illnesses are mostly occurring amongst the aging population. So you have speakers after me who will be talking about that. The other important thing which really is happening is all is interlinked. When we talk of public health, we also talk of prevention and promotion. We see insufficient physical activity. As a person grows old, the physical activity levels also are strongly constrained. So as you can see in the lower countries, lower quintile countries, you would find that these are World Bank categories, but so the low income countries, it's felt maximum because they are poor, nobody looks after them, they don't have enough to eat, they are largely uncared for, so they don't have any physical activity, they remain huddled in one corner, nobody to look after them. Take the case of living arrangements. This is something which has been on the headlines of papers. We see people dying alone, not recognizing that they've been dead. Now the country is undergoing such news from all over the place. It was different in the rural areas, it still is different partly, but urban areas definitely. Living arrangements for the elderly is another great concern. A study undertaken in Kerala, Tamil Nadu, Maharashtra, Orissa, West Bengal, Punjab and Himachal Pradesh by the same Helpage India, because they do a lot of work on old people, suggests that almost 1/5 of these large number of elderly people, they live alone. And this has registered a sharp increase in the past 2 decades, and as I was saying, This is more evident in the case of elderly women because traditionally we have an age difference between the husband and the wife. So the husband dies and the wife is left alone to live quite alone. So with poor social security arrangements for the elderly, it is not surprising that around 37 million elderly in India are engaged in productive work. This is very old data, but I'm sure things have become worse, not better. People have to keep on working. They can't sit back. They can't do things which they want to do. A majority of these workers are illiterate or have limited levels of education, so you can't put them to jobs which would be perhaps ideal for the elderly. Half of the women elderly workers are from the two poorest consumption quintiles. So what does this indicate? This indicates that illiteracy and poverty are pushing the elderly to undertake work outside home as survival strategies or even out of compulsion. And remember, these are not works in the organized sector. They are exploited, they are made to work, and they also suffer from different morbidities as a result of working in such unorganized situations. So if we summarize, I think we are concerned because we have large numbers of older populations. We are concerned because older populations are worse off in health. We are concerned because most of the people in our country with this situation have low incomes, and these low incomes fare worse than the higher incomes. And if you have worse health at any age, that is associated with less satisfaction. I don't feel good if I'm unhealthy. I have high stress and presence of chronic illnesses. Similarly, worse health is also correlated with difficulties with work and with household activities, and they go on being badgered and battered and being told that they are of no use to the society any longer. So my last request during this deliberation would be, while you go through the deliberations throughout the day, please try to focus on better functioning of these old people who are going to live longer now, both their physical well-being and their psychological well-being. How can they function? It's not like the system will provide everything. The community has a role, different sectors have roles, so we need to outline, understand, and then look into what we can do to improve their health and well-being and decrease disease and death. Just to remind you that the Ministry of Social Justice and Empowerment had a national policy on older persons in 1999. Started it to address issues related to aging in a comprehensive manner. We know there are different types of grants in aid in the integrated program for the older persons, under which financial assistance is provided to voluntary organizations for running and maintaining projects. These include old age homes, daycare centers, physiotherapy clinics. There are few, but that's not enough, and the system sometimes doesn't work well. Introduction of the National Program for Healthcare for the Elderly in 2010 has been done to provide separate and specialized comprehensive health care. Actually, you can't pick up one thing because their lives, like all ours, is a complex lot with interlinking of many such things. So it has to be comprehensive health care. Major components are establishing geriatric departments in 8 regional geriatric centers. Work is underway. And strengthening healthcare facilities for the elderly at various levels in 100 pilot districts. This scheme is now being expanded in the 12th five-year plan, but we don't really have very good evaluation results. So I would end by saying that I'm sure all of you would agree that aging matters. Aging is there, the population is aging, and we are concerned because we don't want aged people to end up like this. We want them to be happy, healthy, and a very, very productive part of the population in whichever country they live, whichever district, whichever, may it be rural, may it be urban. Everyone should have equitable access and enjoy all the facilities equitably. Thank you very much.
Thank you, Dr. Dubey, for your eloquent presentation. I think you can join us over here. The questions they might be there. So I think you know what is the geriatric age group means. What is the age actually? Cut-off age? 60. 60 in our country is still 60. It's 60 years. Now, so ma'am has spoken about the social and demographic aspects of aging. The aged population, they comprise a very large segment of the population, and she has spoken about it nicely and the problem specific to it and why we should be worried about the huge geriatric population, why the government should institute various programs and plans to take care of the elderly. She has spoken on this topic. So now if you have any questions or comments, we can please.
My comment will be the questions can come at the end, sir, because I'll be around, I'll come and join later. Because there will be lots of presentations which already might answer some of their questions. So let's do it at the end? At the end of the whole session. I think it would be better than. No, I will. I can't run away from this place. Not a person. But anyway, if you just have any quick observations or comments, you can. You can.
Just to show that you are interested and you are listening actually.
Actually,
ma'am, this National Board of Health of the Elderly NPHC has not done very good work.
Yes.
In West Bengal, it is stagnant now. I went to Swasti Bhavan and inquired. They are telling me it is in a stagnant state.
yes.
They have started in 3 districts in West Bengal, but it is still stagnant. More work should be done. And in Calcutta and West Bengal don't have a national center also, regional center. 8 centers are there in all over India, but not in West Bengal, as yet.
So which gives again food for thought for people working in West Bengal, for people working in tertiary hospitals, how they can think of opening up some more centers. Actually, we need to we need a lot of advocacy for this, with the data, with studies. We've got to approach the government. It's, as I said, it cannot be a blame game. Each one has a part to play, and we've got to do more studies. We've got to show people that yes, this is necessary and how this will help. I think that's the best way of getting things done. If there are no further questions, we can go to the next speaker. Thank you, and if you, I know the timing of the end, so I'll come back.
Sir, we have to request sir to give the certificate.
Okay. Thank you.
Thank you, ma'am, for enlightening us with a key area, the geriatrics, the burning need today. Our next speaker would be elder abuse, current scenario. Ma'am, please come on the podium.
I actually prefer to walk around. So can you hear me in the back? No? Okay, so then I'll just stand here. Before I start, I'd like to thank Professor Dover for her very interesting talk and her outline of the problems in India. This one. Okay, as I said before, I just want to thank Professor Dr. Dove for her interesting talk on India. I think it very well sketches the issue at hand for India and also other developing and middle-income countries that have the challenge of both dealing with lots of public health issues on a population level and at the same time having an older population that is growing older and older and increasing in both amount and percentage of the population. So today I was asked to talk about elder abuse, which is one of the topics I study in the Leiden Academy on Vitality and Aging. So just to give a brief background sketch, I'm officially a social anthropologist, so not a medical doctor. And I study social networks and social support among the elderly in the Netherlands and some other countries as well. Our institute is a knowledge center on aging and vitality, and we study aging multidisciplinary. So we have medical doctors, economists, sociologists, public health people, all together in one institute because we believe that aging is a very holistic problem. And as Professor Dove has sketched, it's not only psychological problems or physical health problems, but also mental health problems, financial challenges, and other issues that come within an aging population. So, as sketched, India has a growing older population and other countries as well, so elder abuse will also increase relatively, maybe not, but definitely in the number of elders affected by elder abuse. So today I want to just give a brief introduction on some basics of what elder abuse is, and I'm trying to elaborate a bit on India, because I was expecting a crowd from India, of course. But I couldn't find much, so there's still a lot of work to be done. So what I will first discuss is definitions and history. Then I will tell you something about the prevalence, both in India, in the Netherlands, and worldwide. Then some intervention strategies, by example of the Netherlands again, and some research details. So to start, I'd like to start with this case study. And normally I would be walking around now, but if you can read the case study, and then raise hands for those who think that this is a case of elder abuse. So who becomes suspicious? Who believes this is might be a case of elder abuse? I see one hand in the back. No one thinks it's elder abuse? You think it's elder abuse? Can you explain why?
Because the son who is supposed to take care of her mother is not giving her sufficient money which she can spend for her to live happily, to live up to her expectation. And so she is being tortured mentally, though not physically, she is being tortured mentally. So we can take it as kind of abuse.
Yeah, thank you. That's a very good answer. Indeed, you can be suspicious because she does not have enough money for her basic livelihood, and that's one of the conditions at least, and maybe not legally here yet, but for example in China it's already legally conditioned. Now if we then go to the definition of elder abuse, we've seen a very large development in history of what we consider elder abuse. Because elder abuse can be considered a criminal offense, so legally something that breaks the law, or it can be seen as a violation of rights of this elder lady, for example, or it can be seen as something breaching the laws of what we consider normal behavior, so more or less, or social construction. Now, in the very beginning, scholars have named it granny battering or granny bashing, usually referring to females, older females who were physically assaulted. And also, for instance, in this other article from the UK, battered granny. So again, physical violence against older women primarily. But if we look at the current development of definitions, when we start from granny battering, it has gone on to elder abuse and mistreatment, which included the risk factors for elder abuse. And also included different forms of elder abuse, not just physical assault, but also psychological assault and financial deprivation. And later on, it was already termed old age abuse and elder mistreatment, and it also included males, not just females, and it also included prepositions on, for instance, the relationship with the perpetrator. And then finally, if we look at the current definition, usually referred to as elder abuse, it takes into account also the context of the situation in which elder abuse occurs. And this is the definition. The current definitions most commonly used is WHO definition developed in 2001. Elder abuse is a single repeated act, so it denotes that it can be once but also several times, or a lack of appropriate action, so it includes omission and commission, so doing something and refraining from doing something, as in the case study, where there's an expectation of trust, so you trust a person who's trying to take care of you, which causes harm or distress to an older person. So this is the WHO definitions most commonly used nowadays. One of the issues in this definition is that there are certain terms which need further explanation or further definition. So for instance, if I would ask you, what do you consider an older person? What do you think? Anyone? What would you consider an older person? In terms of age? 60 plus. Yeah, I think 60 plus is a very standard definition in India. But if you would go to the Netherlands, 60 is considered a bit low, actually. Normally we have the age limit on 65. And that's also because our life expectancy is a bit higher. The morbidities that come with aging usually start a bit later than in India. So this definition leaves that open, which makes it on the one hand very applicable to different countries, but on the other hand a bit difficult in seeing it in practice, whether this is an older person or not. One of the solutions that we use in the Netherlands is that we look at what kind of situation creates the abuse. So if it's because someone becomes vulnerable because of age problems, then we consider it older abuse. Okay, so what types of elder abuse do we distinguish? In general, are distinguished physical abuse, so assault or sometimes battering or these kind of physical assault. Sometimes in physical abuse, sexual abuse is included, sometimes not. Then there's financial abuse, which we've seen in the case study, psychological abuse, so that includes scolding, sometimes manipulating people, neglect, so not giving enough sufficient care to be taken care of, and a violation of rights. So that includes, for instance, unlawfully taking the mail or making someone signing documents or secluding someone from their environment. So most of the time, however, we see that these forms come together. So physical abuse often goes together with psychological abuse, financial abuse goes together with financial abuse, for instance. So there's a lot of comorbidity as well in this abuse. So if we look at measuring prevalence, just a quick question, are you all familiar with the difference between prevalence and incidence? Yeah, can you explain? Yes, very well. Yeah, so in the front here it was already said, so incidences are the new cases. When you ask in a survey, that's the new incidence, and prevalence is during a certain period. And so we distinguish between point prevalence, so at that point, year prevalence, so over a year, or lifetime prevalence. And in the elder abuse case, usually lifetime prevalence means from a certain age that one considers someone old. So 60 perhaps in India, 65 perhaps in the Netherlands. Right. And this has kind of effects on the results of your prevalence as well. So because if you start from 60, you include a larger population than 65. If you only measure the last year, perhaps your validity might be, or your liability of the reported data might be higher because it's closer to the present, people remember better than, for instance, lifetime prevalence. So these kind of things are something to consider. And also there's a difference in sampling characteristics. So who do you ask about elder abuse? Are those, for instance, the guardians of the older people? Are those the older people themselves? Are they living in the community, or are they living in an institutional setting? That also differs because they have different risk factors for elder abuse. So how do we measure elder abuse? There are two ways of doing that. Specific instruments developed specifically for elder abuse, and those are included questionnaires. I will show some examples. Observation, so instead of asking people, simply observing. Indirect observations, and then there are general instruments which might also be used, for instance, for partner violence or family violence of different kinds. So to give an example, I will later give the example. So if we look at prevalence worldwide, I found one study in India from 2006 which found a prevalence of 14%, which is quite high. The study was done in 2 villages in a community sample by a survey which is commonly known as the CTS, the Conflict Tactics Scale. In that scale, people are asked about different behaviors that have happened in the past, and then from the answers they distinguish whether someone has experienced elder abuse. So this was a year prevalence. In the USA, quite recent, in 2010, they found 7.6, also a community sample. Finland, they did their study in 2 different villages, and they distinguished, so the left is males, the right percentage are females, and this is the lifetime preference. And in the UK, they found 4% year preference in a community sample as well. There's been one systematic review on elder abuse preferences by Cooper et al. And there you can see that the range of prevalence rates is very wide. It ranges from 3.2% to 27.5%. And for reasons which I've explained just now, actually, because in the 27.5% were people with cognitive decline. And that's a very risky population. They are usually at high risk for elder abuse. And the 3.2 was in an independent living younger community sample. So sampling strategies do influence the prevalence rates that you find, but they do indicate altogether the same risk factors. Now, if we look at community population, so independently living elderly, the variations are between 2 to 10%, and in general, people assume that it concerns about 6% of the elder population. Now, if we look at prevalence in the Netherlands, just to give you an idea, there were only 1,700 reports in the past year, which doesn't really give away how many people there are, because in general, studies indicate that about 1 in 14 cases is reported, and most of those cases do go unreported. And you can see that also from the reports to the police, which is really low, and the official prevalence study that's been done in 1996, and probably there will be a new study in the coming years. Now the instrument, which I announced already. So this is a brief instrument which is indirectly asking about elder abuse. So 15 questions in which you can kind of ask an older person about elder abuse without specifically asking about it. Another instrument is an observation-based instrument. This is for a carer or a medical doctor or nurse to fill in after seeing the older person. It's a very brief questionnaire, 1 to 5. We've tried this questionnaire in the Netherlands with health professionals, and they're very excited about it because it usually helps to kind of explicitly mention their hunches on what they find in the study. Okay, then there's another indirect observation which actually goes into the signs of abuse, which I'll discuss a bit more later, but you can see that you tick the boxes of the different kinds of signs that you've observed. And this is called the suspected abuse tool, and usually it's also used to ask about from third parties reporting. So not just from the older person, but someone who's, for instance, in the neighborhood and suspects abuse. Now, the general instrument which I discussed and which has been used in the India study is the CTS, the conflict tactic skills. So these questions are in Dutch actually, but one of the questions reads, for instance, so it starts by asking in your 65th year. So in India it would probably be in your 60th year. Did something like this happen to you, and how many times did that happen to you? So it goes into detail about what kind of behaviors other people have shown to the older person. It's considered a very reliable questionnaire, but it's 51 questions, so it's quite lengthy, and the interview can take up 1.5 to 2 hours. So it's not necessarily an easy instrument to use. Now, what risk factors can we distinguish from all these prevalent studies? They're demographic risk factors, especially being, so with increasing age, increasing risk, basically, that's the rule. And being female is also seemingly of higher risk. There's still some mixed evidence on that, but in general, studies seem to indicate that. There's social risk factors, social isolation, limited support network, or having to rely on only one person increases the chances of being abused. Then financial risk factors, especially being from a lower socioeconomic class, because basically they have limited resources to cope with some of the challenges in aging, or because they have limited resilience in terms of how they can cope with their aging situation. Health issues, so with declining health, more morbidities, for instance, that increases the chance of elder abuse as well. Psychological risk factors, so for instance, all kinds of psychological disorders, especially depression, mood disorders for elderly are a risk factor for becoming abused. And then finally, a family history. Still some mixed evidence there as well, but it seems that if there is abuse within the family, either child abuse or partner violence or these kind of things, then the risk of becoming violent in later life, of being exposed to violence in later life, is also higher. But the most important risk factor, after all, is that all of these factors, of course, increase the dependence of an older person on someone else. So in brief, that's kind of something to pay attention to, that if dependence increase, whether it's financial, whether it's social dependence, or some other form of dependence, the risk of abuse increases. And that's why it's not just a health issue, it's also very much a social issue if you look at elder abuse. Now for the perpetrator, one of the important risk factors is stress or burden because of care load, for instance. Psychological risk factors, these include psychological disorders or psychiatric disorders, for instance, behavioral problems, schizophrenia, these kind of issues, but also, for instance, addiction, especially alcohol or drug addiction can increase the likelihood of someone becoming a perpetrator of abuse. Some financial or other form of dependence, for instance, living with an older person and being dependent for the perpetrator on the livelihood of the elderly person, can increase the risk of elder abuse. Again, a family history, so being abused yourself or having abused in the past is a risk factor for elder abuse. And one of the recent studies has shown that lack of empathy. So not being able to position yourself in someone else's situation, especially in the elderly situation, how he or she might experience the aging process, increases the risk of elder abuse. Then finally, we also distinguish risk factors in the environment, and these include ageism, so discrimination on the basis of age, sexism, discrimination on the basis of, especially in this case, female, being a female, and negative attitudes, so general negative attitudes which might be systematic in the environment. Cultural norms, what is considered appropriate, what is not considered appropriate, how should you behave towards an older person and the other way around. That's another risk factor. And now I wanted to give you some examples of what it entails, elder abuse. So this is an example of physical abuse. You can see it quite clearly from the lady's marks. Now one of the distinguishing markers of elder abuse, similar to, for instance, children abuse, is marks which cannot be caused by simply falling, for instance. So in this case, you can clearly see that someone grabbed a hold of her, and then on the inside the marks are, which is not a place where you fall. So that's why you can see it's elder abuse. Then for the other forms, I have no pictures because it's hard to take pictures, for instance, on psychological abuse, but you can see that these are some of the signals that you can detect as a medical doctor or public health professional. So that includes especially confusion and fear, sometimes kind of scary behavior towards others. Is that me or no? Sleeping and eating problems, sometimes very apathic behavior. For sexual abuse, especially marks around the mid area. Some people show very exposed sexual behaviors, others are very scared when people try to touch them, so these kind of things. Sometimes nightmares and depression are also an indicator of sexual abuse. Violation of rights is usually observed through the environment, and that includes, for instance, people not having visitors, people not being able to receive personal mail, or being controlled, or someone is forcing them to sign documents. So this is also something, a general issue in society, that people, for instance, from official institutions also have to pay attention to whether someone is actually wanting to sign a document, for instance. Now, as an example of neglect, I've brought two pictures. So here you can see a house which is basically full of stuff and someone not being taken care of very well. So what signs on the elderly are, for instance, dehydration, not having enough food, a very dirty environment, sometimes frustration or sadness because of the situation the elderly lives in, or very much trying to attach to someone if someone is visiting, not wanting the visitor to leave, or some kind of behavior like that. Besides the signals of elder abuse, there are also protective factors which you can also use to treat elder abuse, so to say. Social support, or an expanding social network, is one of the things that protects elders. Additional care assistance, especially if they're dependent on one carer. If you add additional care, that might improve the situation. And empowerment of the elderly themselves, so that includes being able to say what they do or do not want, being able to speak up when something doesn't go well. And this especially leads to power and control theories, which believe that there's some kind of power balance in a relationship. So if the balance shifts towards someone having all of the power in the relationship balance is off, and therewith might increase the risk for abuse. Now in the Netherlands, just to give you an example of what you could do in terms of elder abuse, we just introduced the reporting code for family violence and child abuse, which tries to stimulate intervention in elder abuse by having a code, not a kind of law, but a code. So that means some behavioral code that every health and paramedical professional should work with, just to support the people that see elderly on how to deal with this. So it's a reporting code. It's not a reporting obligation, but a reporting right for the professional. And in the appendix, there's a special section on elder abuse and what signs or signals to pick up in terms of elder abuse. And it includes a risk assessment and a roadmap. So what kind of signs should I pick up? How should I go further? And what are the next steps? Now this is what it looks like, and it includes also partner violence, elder abuse, child abuse, and honor-related violence. And it's all the same steps for every different form of family violence. It's the same step except for children's abuse, because they're minor and their legal status changes. So if we look at the 5 steps for acting upon signs of family violence and child abuse, so all of the forms, these include the mapping of signs. So some of the signs I just showed you, that's step 1. Then step 2, consulting a colleague if necessary. And if necessary, also consulting what we call the support point of family violence. This is a kind of support centers all around the country that help in cases of family violence. I'm not sure whether there's something similar in India, but otherwise consulting a colleague. When consulting a colleague, when it concerns someone that is of normal age or of older age, it's very important that you inform the other person, especially as a medical doctor, that you professionally have a professional secret, of course. You're not supposed to discuss case studies unless there's an urgent need on behalf of the patient. So you need to inform that colleague about that. Then, if possible, have a conversation with the concerned elderly. That's also very important, because although the elderly is suffering elder abuse, it's also important to include them in the process of deciding how to continue with the situation. Then it's important to estimate the risk, the nature and severity of violence, and this is also important because you have to estimate, okay, how important is it, when do I need to act, is this a life-threatening situation and I need to act immediately, and I might not be able to gather all the institutions around to organize something differently, or is it something that can maybe take a week or 2? And then decide on organizing help or report. So in the Netherlands, there's a quite elaborate section on help and support. So there's the Family Support Center, which you can call in case of advice. But there's also, for instance, health professionals who have geriatric networks, where you can consult others with professional secrecy. And in most cases, the elder abuse cases are not reported still, but people do discuss them with the elderly person and with the perpetrator. And then different institutions can be involved. So that includes legal repercussions if it includes a criminal offense, but it can also simply be getting extra home care, for instance, just to remedy the situation in case a perpetrator is for instance, burdened by the care load. In most cases, so it's not reported to the police, and this is also because an older person is usually relying on this one person. And therewith, if you remove that relationship, the older person might be totally alone and left on its own, which might not be the most beneficial situation for the older person. So usually then the strategy is to remedy the situation, talk to the perpetrator, maybe find additional support, and then only to report it. In case of financial abuse, the cases are a bit different. There's also less stigma around financial abuse. It's somehow less considered, less shameful financial abuse. So in those cases, usually criminal offenses are reported. So what are the judicial issues, especially for older people? There's of course competence. So how well is the older person still able to make a decision? Is he or she still cognitively able to make that decision? It's a very difficult decision. In the Netherlands, incompetence of decision making can only be decided upon by a psychologist. So that requires a different process. But it's definitely a thing to take into account with the older people. Nevertheless, even if an older person is incompetent or considered incompetent, it's very important to remember that someone still might have certain preferences or wants something different than you might have in mind. So it's still very important to talk to the older person. Then for medical doctors, it's important to remember that there are certain grounds to share or receive personal data. These include if the professional is directly involved in the treatment of the older person, it's allowed to share information. There's certain legal possibilities to share information if it's, for instance, life-threatening. And then there's the conflict of duties law. So if you consider that the elder abuse is so severe that it might threaten other parts of your care, then it's allowed to share information on the older person. Now I wanted to go through a case with you. This is from a study in the US, which was this case was proposed to 239 undergraduate students between 18 and 55 years. And the first question they were asked was, how abusive is this behavior? So I'd just like to go through this case study with you guys. So how abusive is this behavior? What do you think? Maybe someone in the back? Any answer is okay. Yeah, I had you already. Anyone in the back can answer this question?
Violation of rights. Violation of rights. Violation of rights.
Violation of rights? You think it's a violation of rights? Can you explain it?
She's not been explained what she is given and why she is given.
Yes.
And she is to be, suppose that since that she is a depression patient and she needs treatment, apart from without giving her treatment, she is giving her some sedatives and making her sleep.
Yeah, yeah. So that's a very good answer. So he considers it a violation of rights because she's not being informed in what kind of medication that she's been taking. So second question: how acceptable do you think this behavior is? Okay, I see someone there answering. Can you repeat? Yes, indeed. So not acceptable because? I don't think it's working. It's okay.
Because she has the right to know that what medication she is giving. But her daughter never told her that she is giving her sedatives.
Yeah. Yeah. So you think she has a right to know?
Yes, of course, of course.
Okay. Now, just raise your hands now. So how likely would you report this as elder abuse? Yes, two here, two here. So I think the majority would report it. It looks that way. Yes. Okay. Now let me tell you about how the American undergraduates would answer this question. So they considered two variables in this case studies. First of all, the relationship between the mother and the daughter, and then the disease the mother had. And in addition, they also considered the demographic background, and of influence was, for instance, their experience with informal care. So the results of the study show that the relation of influence, so that the relationship with the mother and the caring relationship was of influence in estimating how abusive is this, and their experience with informal care. And in the end, about 54% of the students would report it. So half actually didn't want to report this as a case of elder abuse. And those that did report it were the ones with experience with informal care. So you can see there's a difference there. Why this is the case, we don't know. Because part of the issue in elder abuse is that the research is very limited. So if you look at the past few years, we do see an increase in research of elder abuse and the number of publications as a result of that. You can see here, it only started in the 1970s, which is relatively recent. But if you look at this is a study being done in 16 different databases. It included almost 7,000 articles, of which 1,700 were about elder abuse, but only 590 were actually novel research after removing all duplicates. So only 519 studies, and 14 studies were only intervention studies. So you can see only 14 out of those 519. So we need a lot of work still on what is the good way to deal with elder abuse. Now, just as comparison, these are results from children's abuse, so child abuse and neglect. So there were only a few journals included. You can see the names here. 6 specialty journals focused specifically on children abuse between a period of 10 years. Not 40 years as in elder abuse, but 10 years. And there were more than 2,000 articles. So 4 times as much on children's abuse than on elder abuse. So just to give you an overview of how neglected this area is, so we still need a lot of research. So just to conclude my presentation, I wanted to give some details about how to explain elder abuse. This is still tentative hypothesized models of elder abuse, but still just to give you an idea. A lot of people explain elder abuse by focusing on interpersonal characteristics, so psychological factors, the relationship between the perpetrator and the older person. And then there are several theories from criminology which focus, for instance, on resource theory, so the number of resources an older person has available, and how he or she can cope with adverse events. Or, for instance, control and power theories, which I just explained. And then there are theories from social psychology, especially in terms of the positions of older persons in society, and how groups interact with each other. For instance, that older persons are considered one group, especially when they increase in size, and they have a different position than, for instance, younger persons, and if their functional value in society decreases, some of the theories pose that this increases the likelihood of elder abuse. There's still not a lot of proof on that, however. And then there are sociological theories, for instance, in terms of cohesion, or in terms of how acceptable different norms are. And then there are theories from feminism, which propose that especially females are considered weaker, and there it becomes more acceptable to abuse them. But again, not enough evidence yet. So if you want to know more, we have a master program on vitality and aging. It's a one-year Master of Science for medical and paramedical bachelors and masters. And as I said before, this is a kind of holistic master program. It includes both medical studies, so it includes multimorbidity, it has clinical work, clinical courses, but also sociological issues and, for instance, the background, both evolutionary and in biology of aging. Now, it's a small selected and international group, so we do select our students. There's a maximum of 20 students admissible. We have international guest lecturers coming. On average, there are 6 for each course. And there are several career opportunities, which includes a scientific career, a clinical career, and a career in healthcare policy. If you want to know more, I'll also be talking in some more detail, not too much, but on public health careers opportunities later today in the afternoon with some of the esteemed professors here. I thank you. If you have any questions, I think we still have some time, right? We still have time for questions?
Yes, thank you, ma'am, for your nice presentation on elder abuse, defining it, telling out the equivalent, the types, the legal implications, everything. I think they have learned a lot, I think they understood. Anyway, so if you have any comments or questions, you can do now. Ma'am, if you are she has come from USA.
Here, the case you just showed in the US,
Yeah.
where the mother was given sedatives.
Yes.
You say 54%. 54% were willing to report.
Yes.
Now, is this reporting means reporting to police or reporting to the support point?
Support points.
Because the daughter needs to be counseled here, so we should report to the support point. Okay. And from your statistics, we see that elder abuse is on rise after as the years goes on. And what do you think can be a possible reason that the elder abuse actually is on rise?
I think there are 2 ways of distinguishing the rise in elder abuse. One is better detection methods. That's one thing. More knowledge about it too, so people actually report it more often. Then another issue in rise is the absolute number of older persons is increasing. I'm not sure, because prevalence studies are rarely conducted twice in every country, so it's not clear whether the actual prevalence rate, so the percentage of people having experienced elder abuse increases. That's unknown. But we do see that there's very little variation between countries, which is somewhat surprising if you would consider that countries deal very differently with their older persons.
Thank you.
You're welcome.
I have a question. What do you think is the best way to take care of the elder people?
And one important that I'm very bad about is the brain. There are 2 types of processing. One is the body, neural body, and another is the fiber, white fiber. And these fiber is equally important. That's called the white matter. This white matter connects different parts of the brain. If they are damaged, you get also memory loss, or you get cognitive decrease. This is like a telephone center, right? The 2 centers are connected by way of your cable line. So in the brain, you can take it a very great telephone center, and you have got connection between the different exchanges. Now, the common cognitive problem which you see following stroke are memory, attention, particular focus attention, perception, that your thinking is impaired, and you get problem in communication or language. These are the 4 areas, but any areas of the brain may be affected. And if you have got a stroke in your family, and if you give detailed assessment of this patient, which is called neuropsychological assessment, you will be able to pick them out. Now, what is stroke? The stroke is a condition. Everyone knows that the stroke, you have had a good stroke in cricket, you have got the stroke. Stroke is indicate always the cerebral condition. Sometimes young people think stroke means in the heart. Heart is called heart attack, but usually stroke means the brain attack. And it is a condition where you get, after a stroke, one part of the nervous system gets damaged and you get deficit, which commonly due to paralysis, and it is due to occlusion of blood vessels, or it may be due to rupture. So if there is a rupture, the blood will come from the vessels outside the vessel wall, and they will jeopardize the function of the brain. This is two important. This is two important type of stroke are there. This is called ischemic or thrombotic stroke or embolic stroke. These are these dark area where the whole of the brain almost is one side of the brain has been damaged. And another is that in the CT scan, we saw that there is a high density area, just like a bone, there is a collection of blood. So we call it a hemorrhagic stroke or intercerebral hematoma. This is commonly seen in patients who have got an uncontrolled hypertension. And in our country, we get more hematoma, and less commonly we get ischemic stroke. But in Western countries, we get more ischemic stroke rather than hemorrhagic stroke. The hemorrhagic stroke can be prevented if we can control hypertension. This is one of the very important parts. This is a patient. We saw stroke, this part, this lady, and you know, this is the physical disability, but now people are becoming much more important that apart from physical disability, there may be other problems. So regarding stroke, it can involve any part of the brain. It can actually involve the small vessel, that's the small artery, and it can involve the large vessel. And whole brain is supplied with the cerebral arteries, which is called anterior, middle, and posterior cerebral arteries. I'll show you the distribution. This is the two picture. One is lateral profile, this is the inner picture. These yellow areas, this is called the anterior cerebral artery, anterior mid front part. These cerebral arteries supply the prefrontal lobe particularly, and this red is the middle cerebral artery. This supplies these areas which is that control the voluntary movement, precentral gyrus, postcentral gyrus, and also the speech area, and part of the temporal lobe also. And this the bluish color. This bluish color is supply the posterior part of the brain, and this is the area of the vision. This area of the vision. So if the posterior cerebral artery is damaged, you get loss of vision. If middle cerebral artery damage, you get really paralysis. More on the head side of face and the hand. And if you get anterocerebral artery, you get your intellectuality, which is impaired. That's intellectually impaired, otherwise you get weakness of the brain. Mind that. In the brain, there are two hemispheres. One is dominant hemisphere, another is the non-dominant hemisphere. Dominant hemisphere means the left side. The left side of the brain control our right side of the body, and the left side of the right side of the brain control our left side of the brain. So this is important. Depending on the blood vessel supply, you can get cognitive damage. So what are the consequences of stroke? We get physical disability or paralysis. You get non-physical problem. This is actually were not very assessed by the doctor. But now we have done the studies among a group of stroke patients, which is about 300 to 400 patients. We have shown that depression is very common, which is seen about 1/3 of the patient with a stroke. And we cannot diagnose because we don't have orientation. And unless you treat this depression, you will not get improvement in the paralysis. Second is cognitive dysfunction, which is seen about 20% of the cases, and be coming in detail. The third is psychosis. So these all non-physical problems may be the consequences of stroke. So stroke is a devastating condition and is really a abuse of the brain. Cognitive dysfunction, it may be of two types, very mild, where the activities of daily living. Activities of daily living means that you can get up in the morning, wash your teeth, can take breakfast, you can go to the bathroom, which you can do everything, which is bizarre. This is called mild cognitive dysfunction. And then severe means where activities of daily living compromise, you have become dependent on the family member or the caregiver. Sometimes you get admitted in institution where they take care of the geriatric people or demented people. This now, this DSM-4, you know, DSM-5 has come, Diagnostic and Statistical Manual of the Psychiatry. They have divided this cognitive dysfunction in two ways, mild cognitive dysfunction and major cognitive dysfunction. Now, lastly, I am coming to an epidemiology of post-stroke cognitive dysfunction in India. We have carried out in our city. This is an important sequelae of stroke which I have already told. Post-stroke mild cognitive impairment varies from 71% at 1 month following stroke to 61% at 6 months. It varies from actually whether you have treated the patient at home or treated the patient at hospital. Usually when you admit the patient in hospital, they are the severe patient. And when you give the patient at home, they are not much severe, or you may not have that amount of capability or financial capability to admit them in the hospital or nursing homes. Post-stroke dementia throughout globally varies from 6% to 38%. So this is a long range. It indicates actually that there is a pathological flaws. There are different types of definition, different pathologies have been carried out. Recent studies in India have shown that stroke is increasing. We have actually 10 times increase in prevalence of stroke for the last 4 decades. And there is 4 times increase in the incidence of stroke. This is a study from our which has been published in the Stroke Journal and Dr. Dalal from Mumbai. There was a similar incidence of stroke. And it is expected that post-stroke dementia burden will increase in India. And now time has come where we should control hypertension, which is a master killer for stroke, and reduce the stroke so that the dementia will decrease. However, hospital-based studies have shown a rate which is higher than the community-based study, and this one study has been carried out which is about 1/3 of the patient of the stroke, they have got a dementia. So, there is no comprehensive community study of post-stroke cognitive dysfunction in India. Because if you do study in hospital, if you do study at community, there is two difference. Hospital study is always the biased study because people come from the different areas. But if you do community study, then it is much more, it is an ideal study because here you go to the people and you examine them and assess them. So there is no comprehensive study before our study. So objective was that to determine the prevalence and incidence of cognitive dysfunction of post-stroke MCI or mild cognitive impairment and dementia among stroke survivors in a community background. This is the map of the Calcutta. We have actually 6 areas. We have divided Calcutta in 6 areas. One is the slum area, and the other 5 areas we divide in the north, central, and the south. And we actually collected people by doing random stratified random sampling. This is a very ideal sampling. Now, this survey was conducted in 3 stages. First stage is field worker visited the community. They actually based on a WHO questionnaire, they found out the stroke cases. The doctor examined them, confirmed them, and a neuropsychologist assessed these patient who actually agrees for that, or the family member agrees, and with a validated stool, we have a screening questionnaire. We have got a cognitive screening battery for Bengali validated medium status examination and Kolkata cognitive battery. Everyday ability scale for India, this is very important, which you can assess the patient capability, hobbies, moods, judgment, capacity, ultimately final diagnosis by consensus of the team comprising neurologists, psychiatrists, and neuropsychologists. We did follow up of all the patients after baseline evaluation. We actually followed them over 4 years. That's a very important part, and that's never been done in a developing country. And each visit, the same persons were evaluated for cognition, activities of daily living, and depression of stroke survivors. We operational definition, this is WHO stroke. We do dementia evaluate as per DSM revised criteria, and mild cognitive impairment as per modified Peterson's criteria. And we have published a MCI on young population in Journal of Neurology in 2007. We had sample population which is very massive, with over 100,000 people, of which male slightly predominant than female. Total stroke cases were 853, but it will be sad if you see that about 452, about 50% of the patient died. That's a very kind of bad kind of care which provide, or patient actually they do not get the proper infrastructure for getting treated. When you started the baseline year, 281 cases, excluding all other parameters, exclusion criteria, about 19% has cognitive dysfunction. Now, first year, second year, third year, we have got a slight increase about 21%. Overall, we have got 19%. There is a cognitive dysfunction. And we have take also patient which varies from 9.96% to 7.2%. And there is attrition. Attrition means they did not take part in the survey process because of the fact they actually possibly do not like it, or they have migrated, or some kind of reclusion. Now the result, which is very interesting, that we have a post-stroke dementia. At 3 months we have got 11, which is about 12% of the patient. At 6 months we got increasing rate 15%. At the end of the study 15%, almost 16%. Incidence rate means new cases per year. We have got 3.53, means approximately 1 among 20 stroke survivors develop dementia each year. So you see, it's not a small number, and it will go over 10 years, so 1/3 of the patient actually they develop dementia. Now this is a graphical representation. Age-specific prevalence of post-stroke MCI and dementia. This is the MCI which remain actually initially high and then decreases. But you see this red color with dementia, that means some of the MCI cases they converted into dementia, and that's why the frequency of dementia increases. So if you can treat this patient with MCI at early stage, possibly you can refer to relatively not, you can prevent the progression into dementia. So this is a very important slide. Now we also check why you treat MCI dementia cases. Now this is actually 3 group of person are there. One is post-stroke dementia. This is called survivor analysis. What you know how the patient subject with cognitive dysfunction survive. This group of patient actually has earlier death. So they are this survivor. This is MCI, intermediate. This is normal. So those who do not have cognitive dysfunction will survive better. So it indicates that if you have to treat, if you have to prevent dementia, dementia has increased chance of mortality. That's very important. We have got post-stroke mild cognitive impairment. Estimated prevalence rate at baseline it was 6%. At the end of study it was 3%. Annual conversion rate into dementia is high, it is 10%. That means 10% of the patient on mild cognitive impairment go into conversion into dementia. So 1 out of 10 cases with post-stroke dementia is converted into dementia. So you have to treat at this level. If you treat this level, so you can prevent the development of dementia, which is a reality very, very bad, because this is a kind of situation where you lose your independence and you have to depend on family and nation. With the graphical presentation, you can see the first visit, the green, which is the dementia, with the progression, we see that green color is most prominent, the dementia become more prominent, and this is this rate is moderate dementia, this is a mild dementia. Mild dementia gradually decreases and severity of dementia increases. We did the statistical analysis, univariate analysis, and we found that those who have got first reverse stroke and those who have got a stroke at advanced age, we have got recurrent stroke, or who have got cerebral infarction, which I showed you in the previous CT scan, and those who have cortical atrophy, that means brain so atrophy, they have poorer performance on the minimal status examination and SI. Those with MCI, stroke survivor with MCI perform worse. But those with dementia are more likely than stroke survivor with MCI to have cerebral infarction and cortical atrophy. What it means that when you have got a repeated cerebral infarction, you more likely to develop dementia. So you have to, mostly what happens in our country, after a stroke, they initially get treatment for 1 to 2 months, and when they improve, then they go for treatment. So you have to take measure to prevent cerebral infarction. If you take measure for cerebral infarction by controlling hypertension, taking drug for antiplatelet, you can prevent them from going to the HCR. Now we did logistication analysis. Age at onset of first ever stroke and cortical atrophy predict risks of dementia. That those who have got a brain which is so atrophied, which occurs common in Alzheimer's disease, and those who develop stroke at older age, they are more likely to develop dementia. And age of onset predict the risks of MCR. So those who have only increased age, they develop stroke, their chance of having MCR. So coming to the discussion that global meta-analysis of stroke with the global studies, they have shown about 7.4%. This is the Lancet Neural Rate 2009, but our rate is higher because we did not exclude those pre-stroke dementia cases. So maybe the stroke dementia which are getting, they might have mild dementia, and we have not taken them into consideration. That's why this rate may be high. However, the present rate was similar to a study from Australia, but lower than that of USA. So we have found some parallelism with that of study of the developed countries. Now, mean annual incidence of dementia, that means new cases, which is about 3.53% per year, in this study similar to the above meta-analysis, global meta-analysis, that is 3%. That is, they show development of dementia same as what is occurred in other parts of the globe. 50% dementia cases develop after recurrent stroke comparable to previous studies. So if we can prevent recurrent stroke by appropriate treatment, we could prevent dementia. Some of these cases have been contributed by associated neurodegeneration. That means they might have underlying Alzheimer's disease. And now vascular dementia, they are called that is a combination of the post-stroke dementia plus Alzheimer's dementia. So post-stroke MCI, which is much lower than on that of MCI from the same city. We had initially all patients, all subjects above 50 years who have no stroke, nothing, we have got a 15% MCI. And but post-stroke MCI is only 6%. That's interesting and cannot explain. And lower prevalence MCI may be related to inclusion milder stroke cases in the community. So you do not have all the time bad stroke cases. You might have mild stroke cases. And this lower prevalence of MCI may be related to that mild stroke cases. You have got a major stroke, you will get major cognitive dysfunction. And rate of conversion of dementia, 10% is similar to developed countries like Canada and Singapore, which indicate the factor which produce dementia in our country, they are also present in their country also. Stroke recurrence and cortical upset indicate loss of cerebral mass, influencing higher proportion of dementia. So every stroke recurrence there is some cumulative damage of the brain, and cortical atrophy means generalized loss of brain tissue. Strokes, however, with dementia had less favorable survival. Our age might be an important confounder, since stroke with dementia is 1 decade older than stroke survival without dementia. So those who at an older age, they are having dementia, but this age is maybe a confounder when they are likely to produce dementia also. Our essays with MCI and those without TB have similar survival. So MCI is not a very difficult condition. There is some limitation in our study. We have got a high attrition rate, no validation of stroke dementia with post-mortem autopsy. The autopsy is not done in our country very frequently, and that's one of the greatest snag in the epidemiological study. So you cannot compare our epidemiological study with that of the post-mortem biopsy report. Pre-stroke cognitive evaluation is not carried out, already told you, and our AMAC protocol might have or means legally validated minimal standard protocol might have underestimated capture of non-amnestic cases of post-stroke MCI. Because non-amnestic this is important, because when we do memory loss we call amnestic. If there is no memory loss, there may be no amnesty. And there may be MCI where memory may not be impaired. Their only impairment may be executive function. So if there is executive function in fact, and they are also, you can call it that is a cognitive dysfunction, and BMAC is not fit to include all cases of cognitive dysfunction. So in concluding remarks, that the study from developing countries with a higher prevalence of post-stroke dementia than meta-analysis based on global analysis from the study on post-stroke dementia, which is about 7%. The annual progression rate of dementia to the annual conversion rate of MCI to dementia is comparable, indicating disease progressive factor similar, which is there in the whole country, in other countries. And that is called for urgent need for policymakers to undertake adequate preventive measures to combat stroke, to reduce burden of dementia in developing countries, and implementation of cognitive rehabilitation is very important, and we have got a less number of neuropsychologists. Apart from Kolkata and other university, I don't know whether they give training for neuropsychology. And now the question is very important. We are talking so much about cognition. Does it improve? Yes, it can improve gradually, particularly in MCI variety. But once you develop dementia, chance that you do not get cured. So you have to stop from conversion of MCI to dementia. This is study from Stroke Journal 1996. So we can, it's not that we all bad. I must acknowledge my collaborator, Dr. Geriatric Das, who have done the mainly the cognitive dysfunction study, like in the past, but done on depression. OBG, who has done all the statistical, Malay Kushal, psychiatry, who is one of the co-investigator, Iman Kantirai, who have with a neurologist, Tapush Banerjee from the Fearless Hospital, National Neuroscience Center is one of the very enthusiastic person, and Praveen Parman, University of California, Professor of Biostatistics, they have done a lot. Indian Council of Medical Research who have actually funded, and Dr. Mary Ganguly, Professor Psychiatry in Pittsburgh University, USA, who has actually examined this, improved this, and helped us putting out the flaws in our study so that we look very good. Thank you very much for your kind patient care.
Thank you, Professor Das, for your elaborate lecture. You have told us about the original work, what you have done, and it's an excellent study, interesting study. And now, if you have any questions with Professor Das, you can ask him. One or two comments or questions. He is ready, but one or two questions. Yes.
Does this conversion of MCI to dementia occurs only in those patients who are not treated properly or who have recurrent strokes, or it will occur anyhow in some portion of patients?
That's a very good question, but we cannot answer at the moment. But it is possible that if we do not treat patient properly, they are having chance of going into dementia. Because all stroke patients, they have got hypertension, mostly as well hypertension, diabetes, smoking is a very important in our country, a very important problem in our country. And this smoking not in the form of inhalant smoking, chewing tobacco, equally responsible, maybe worse than that. So if we can prevent it, we can stop this or control the factor like hypertension, diabetes, and hyperlipidemia, which is high cholesterol. So possibly that will prevent it.
Sir, are there medications available to prevent this transit to dementia?
Any medication? Yeah. If you treat the preventive factor of stroke, along with there is doubtful, but say donepezil with a drug which you can give it. They say that maybe in patient of dementia due to stroke or blood pressure, vascular disease. Yeah.
Sir, severe cognitive dysfunctions are reversible or irreversible?
Usually I told it that irreversible.
Irreversible.
Yeah. If it's a mild, you can reverse it, but it is severe.
So why do you think the incidence of stroke is increasing in our country?
That's a very interesting. One of the most worst is the urbanization. Apart from urbanization lead to your increasing stress, increasing hypertension, and we find that there is more of a smoking, less manual work. So increasing alcoholism. We see alcoholism in the southern part of India, particularly Kerala and Bangalore. They have a higher rate of having stroke due to this possible, and they have got a high rate of diabetes also.
So I think those metabolic syndrome.
Metabolic syndrome is there, true. Metabolic syndrome explains the younger onset of stroke. But metabolic syndrome is a conglomeration of the disease of hypertension, diabetes, smoking, hyperlipidemia. But they can explain that the possibly genetic origin, and they are much more actually dangerous for the young people. And the Indians develop stroke, particularly heart disease at young age.
So thank you, sir. We conclude here, and I think that will announce it. Health weight. There is a health weight session with Dr. Olushanga Kaur, who is speaking on cancer and geriatric population.
Good afternoon. At the outset, let me thank the organizers for being very thoughtful on keeping a session on geriatric oncology, which I think will touch and reach all the population of doctors and administrators and public health workers who will be dealing with them in one way or the other. Now, geriatric oncology, as the name of the topic suggests, is a great challenge. It's a challenge for the administrators because of the health economics. It's a challenge to the physician because you have to take so many factors into consideration, especially the comorbidities, it's a challenge to the family members because they have to cope with many diseases. It's not cancer itself, but it's a conglomeration of a lot of things, including cancer and the physical performance status of the patient, the comorbidities, the challenge of using standard of care. So it's a very, very complex situation, and I congratulate Indian Society of this Preventive Medicine and ISMOPH for being very thoughtful in keeping this topic for discussion over the next 20 minutes. It is very commonly said nowadays, to make things lighter, that there has been so much of growth in this population of pediatrics and geriatrics that if you are doing oncology, either you're a pediatric oncologist or you're a geriatric oncologist, because it is these two extremes of age, their maximum of cancer patients are seen. And in the young adults and others, it's much less. So we have to choose between any of them. To begin with, I give you an overview of the ABC of geriatric oncology. First, it is the patient, is he going to die of cancer or is he going to die of comorbidity? Because if the comorbidity is stronger than the cancer, then your health economics as administrators, you should put it in that way. Next is whether he has enough life expectancy to suffer the consequences of cancer, and then only you will think of treating the cancer. Otherwise, you will give him supportive care or tender loving care to make his life more comfortable over the last few days. And the most important, which I will deal with a bit more details, is the patient, will he be able to tolerate the treatment, which is a lot of judicious decision making. Fourth is, as you all know, very often the patients and family members say that will it be worth giving him the exposure to the toxicity of your treatment? So, are the complications of treatment commoner in older? Should we think in a different way? And fifth, very, very important, which all of you can contribute, which Taposhda was telling, the social networking, whether it is adequate to support this treatment in the elder. So, it's the caregivers and the social networking that becomes very, very important. So, my entire talk will be focused on these few points, and the third point I'll give a bit more in details. So, is the patient able to tolerate treatment? This is the decision routinely based upon what? What do you base it on? The chronological age. Any patient who enters your office as practitioners, the first question you ask, what is your age? Age is 85. You have such a nihilistic approach to the patient. Okay, but he's had his life, let him go, whether it's cancer, whether it's Shamolda stroke, nothing matters. So that's a chronological age which you get the input. But since this is a World Health Organization as a co-partner, I'm putting a more global picture. It's a heterogeneity of aging which is very important. Look at this. Here is a lady who is just barely 68 years old, but she's already wheelchair bound, has got multiple osteoporotic fractures. This is not the same as this lady who is 94 years celebrating her 95th birthday. And still she's so jovial, she's with her family, this is her social support, her fitness is absolutely remarkable. So don't take the chronological age alone. You must understand the heterogeneity of aging. So it's the performance status that is very important. So chronological age is not equal to the physiological age and is not equal to the mental age. All these things are different. And that is how you should evaluate any patient, geriatric patient, entering your office or as public health workers when you do the decision making. So my talk will be outlined on these. What is geriatric oncology? What is the burden of cancer patients in older adults? What's so special about growing old? All of us will grow old. Then how people look at us will change. So what is it that will change? What are the emerging research in geriatric oncology? And of course, to give you a conclusion of what I'm talking. So, geriatric oncology is oncologists implementing geriatric principles to manage older patients with cancer. So, you must have an input of geriatric principles. There is no one precise definition, in oncology who is a geriatric patient, but you will see most of the studies or trials, they have put a cutoff that they don't take patients beyond 65 years for the trials. So you can use 65 as a cutoff, you can use 65 to 74 as young and old, 75 to 84 as medium old, and 85 plus as oldest old. This is how you can actually conceptualize what is the care you are going to give to your patients. Overall, it is clear that aging has led to increased focus on cancer in the older adults. If you start Google of geriatric oncology, you see that it is increasing. The literature is increasing by nearly 100% over the last 5 years. So a lot of literature on geriatric oncology, entire journals being dedicated to geriatric oncology. So it is a reality. It is not just a theoretical discussion. There has been a lot of change in the way we look at geriatric oncology patients. This is a very traditional view, where a lot of importance is given to prevention, that's perfect, screening, how to diagnose, they have a very bad prognosis, this is the usual mindset of doctors, family members, whether to treat or not to treat, lot of importance of quality of life, and of course we start discussing end of life management and some data on the epidemiology of this disease. But there has been a paradigm shift in how we view geriatric oncology. So this is the change in view. And how do we view? We are now being very critical. We do understand that the physiology of geriatric population is different. So the pharmacology, the pharmacokinetics, dynamics of drugs and treatment will be different. So this is the reality. We have realized that. We have also realized that they are not included in clinical trial participation because of our very negative mindset. So we don't know what properly the drugs are being going to be used in this population. But the paradigm is now that we realize we are very biased on their chronological age. So we have started some evaluation, and all of you know the comprehensive geriatric assessment is there, CGA, which is doable. We have a lot of importance on comorbidity. We do assess the functional status. I showed you the picture, 94th birthday being celebrated with children, whereas a 68-year-old is bound to the wheelchair because of repeated fractures. So this is not the same population, though the chronological age is very high. So functional activity is very important. Frailty has been already defined. We are talking not of end-of-life care anymore. We are talking about long-term care. So this is the paradigm shift that has happened in our mindset to the approach towards geriatric oncology patients. The next point is, what is the burden of cancer in older adults? As you all know, older adults are the fastest growing population, especially in the West, and even in India. If you look into the population transition, there is a lot of growth in older adults. Remember that 60% of cancers occur in age beyond 65 years. So though they contribute to say 7% or 10% of the population, actually they contribute to 60% of cancers. And more than 70% of all cancer deaths are seen in this elderly age. So they contribute to cancer, they contribute to cancer mortality. The odds of dying from cancer are 16-fold higher in patients who are in population who are aged beyond 65 years. So in all aspects, geriatric population contributes to the majority of cancers that we visualize. What is the incidence of geriatric cancers in the Indian registry? You know that there is a population-based registry by the Indian Council of Medical Research, which looks into the cancer in the community. And there, interestingly, in the rural registry, it is 25% contribution by the population beyond 65 years. And in the urban registries, you can see that beyond 65 years is contributed by 29% of the population. So in urban, obviously, they contribute more. This in a nutshell is the burden of cancer by the geriatric population in India. The next very, very important, which I will like to deal with in a bit more detail, especially for the students, what's so special about growing old? why we are keeping this topic at all? We can treat everybody the same way. No, we must know what really goes on with the geriatric population. So I have made a comparative chart. If a patient enters your office, is a young adult cancer patient vis-a-vis old adult patient, what is your feeling about it? You think, okay, this is the most serious condition. I must treat it all out. But when an older adult enters, you just have to keep an eye and a vision of his comorbidity and how disabled he is. What is the functional assessment of this patient? We know that in young adult we should go all out. We should be very aggressive because they tolerate these side effects of drugs and treatment very well. But here the tolerability is put into question. So, see, the first question arises here, is he functionally able? Does he have a lot of comorbidity? Next is, will he be able to tolerate the treatment that the oncologist is suggesting? So the third and main goal here becomes, of course, survival and cure. Whereas the goal is quite different here. Goal is at 85 years, you are not thinking that he will live for another 10 years because there are confounding variables. So all your aim is to provide him a very good quality of life in the expected survival. So this is how geriatric oncology is different from adult oncology. So let us take an example. He is a 65-year-old professor of music. He is in excellent general health. He has got a prostate cancer, which is a very mild, slow-growing cancer, and he is not on any chemotherapy, radiotherapy. He is just on an oral hormone therapy. He has been on this therapy for many years, and he is writing a book on musicology. Now, what is his concern? His concern is not whether I live, whether my prostate cancer gets cured. But see, his main concern is, doctor, I am out of energy, I am very, very depressed, I feel weak, I can't concentrate, and I can't finish my book. So his aim in life, his priorities are completely different. He has lived his life, he has been retired, so this is his most important thing now. So it's the quality of life now that he demands that we should take care of. So he feels that the hormones have saved his life, but they have also taken away his energy, his functional status. Can I have some more? So why hormone therapy is the culprit? Because you know hormone therapy here is anti-androgen. That is, they inhibit the testosterone. And anything that inhibits the testosterone will lead to a lot of bone loss, fractures, general energy will be depressed. So all these things actually occur when you give hormone therapy in prostate cancer. So the quality of life is impaired because of the side effects of hormone therapy. So we have to counsel him and motivate him to continue with the hormone therapy. And this is of course the cartoon to show you that anybody is going old, they do have their own way of thinking. They can't jump to conclusion anymore. So they are functionally less active than before. So how do oncologists assess the functional status? Of course, you must do a detailed history and physical examination, and then you come to the conclusion with the help of two parameters that are now available. Two types of performance status is used by oncologists. One is the Karnofsky performance status, and one is the ECOG performance status. One is in 1, 2, 3, 4 numerical. 1, 2, 3, 4 is the first, and ECOG is percentage. 60%, 70%, 40%. And when you do not know all these, you of course utilize the educated guess. An educated guess is always better than an uneducated guess. So this is how oncologists assess an elderly cancer patient. So let us be a bit interactive. Here is a patient who comes, 80-year-old female with breast cancer, who has a sedentary lifestyle. She is a bit obese, she is sedentary, she is able to do some light housework, but she has kept a housekeeper who does most of the things for her. But she goes out daily to the grocery store at the corner of the shopping mall. So what is her performance status? What do you think? Is 0, 1, 2? 0 is fully active, 1 is active 50% part of the day, 2 is quite bedbound, and 3 is of course can't do anything. Okay, you're correct. It's somewhere between 0 to 1. She's not fully active, but she is quite active. So it's 0 to 1. So why we use these parameters? Because these are universally acceptable. So in your prescription, if you write performance status 1, if she goes to another doctor or a healthcare provider, that person will know that when she began her treatment or when she came to visit the first doctor, what was her functional status? And when she is getting treatment or she is progressing with the disease, what has become her functional status? So this is the importance of using performance status in the left-hand side of your prescription before you venture to give any treatment. So I began to tell you that there are a lot of challenges in the elderly because of the physiological and the pharmacological changes. So all of you know what are the physiological changes. You know that the body fat increases, muscle mass decreases, the total body water actually also decreases, the motility, absorption decreases, the renal function and GI function decreases, and all of this we have already had some discussion before are the comorbidities that actually afflict these elderly cancer patients, including hypertension. So what is a comorbidity? It is a concurrent independent health condition which may be a predictor of survival and it will require the administrative resource. So it is very important to understand that because of resource requirements. So the key questions our oncologists ask is the patient going to die from cancer or is the patient going to die of, say, heart attack? That is very important before you judge your treatment. Number 2, will another medical problem limit the ability to tolerate your treatment? Like he's got an uncontrolled diabetes. If you give chemotherapy to this patient, he will end up in a serious infection. So comorbidity not only determines the outcome in the lifespan of the patient, it also determines whether he will tolerate the treatment which has been offered by the oncologist. So these are the major comorbid conditions that can occur in a cancer patient: hypertension, arthritis, heart disease, a whole gamut of this. This is one study which shows that what is the percentage of these comorbidities that can occur. Of course, this is a Western study, and you see that it is very variable in our population, depending on which hospital you are taking the data from, what is their setup. In the community is different, in the hospital it is different. I can share a personal series which I did in my practice. This was a retrospective observational study on the coexistence of type 2 diabetes in newly diagnosed cancer patients. I had included 419 cancer patients. This is an unpublished data as yet. 17.8% of these patients had a comorbidity of diabetes mellitus. So it is to the tune of 15 to 20% in the Indian population. I had already mentioned before venturing to any treatment, you must keep an idea that all the pharmacokinetics and dynamics of the drugs which you are going to use will be altered in an elderly because of the changes in absorption, body fat, distribution, renal, cardiac function, metabolic function, and of course elimination through the liver and kidney. So you must be very careful when you choose the pharmacological drugs. The very important other thing is there is very limited oncology evidence base. So I had told you that in the clinical trials beyond 65 years the patients are not recruited. So how will you get evidence to use that chemotherapy or radiotherapy in this elderly population? And even if they are included, you know, all the good patients are included. Those, they will write, this is the checklist, no diabetes, no stroke, no cardiac dysfunction. So this is not what is going to happen in your practice, in the real life. This is not a real life scenario. In real life, you can't translate the clinical trial into practice because you will get comorbidities, you will get functional disabilities in the cancer patients. So this is the flip side of not having real evidence to treat these cancer patients. So after we have finished, what is so special about growing old? How do cancer patients who are geriatric age group really differ from the young adults? We come to some interesting points on research in geriatric oncology. I have talked about age bias. I have talked about the comprehensive geriatric assessment which we use before we give therapy to these patients. What is the scope of screening, whether there is any scope of screening at all in this population? And of course, I have told you the dearth of elder-specific clinical trials, and because of that, we don't have evidence as yet. So, are they including these patients in future clinical trials? Regarding age bias, I have told you, I showed you that patient 95 years, whom obviously none of us will treat, but see, she's so active. So this is age bias, that the moment I write down the age on the left side of my prescription, I have a bias of not treating the patient. So this is discrimination. And when a 95-year-old enters your clinic, their family members, the first thing they will say, we will not do anything with you. They will do everything, like in our population, Gochona is there. They will do everything, but they will not do the scientific treatment. They are also partially correct because there is hardly any evidence we can offer them. So they try all alternative treatments, and this is what happens in a country like India. So because of the age bias, they are less aggressively screened, they are not staged properly. If you tell them do a CT scan to find out the stage, what will happen? Nothing will happen. We will not do the CT scan. Receive less standard of surgical therapy. Don't do aggressive surgery. Just remove the tumor. Don't do a radical surgery. So you are much less aggressive. You don't treat it properly. You don't use strong analgesics also. He is in severe pain. The patient's family member will say, if you use this drug, there will be a problem in the kidney. So at each phase, you are having age discrimination and age bias. And as a result, you see, beyond 75 or 70 years, most of the patients don't receive any treatment whatsoever. Okay. So what we want to highlight is that because of very limited intervention studies in the geriatric population, we need special clinical trials which will use comprehensive geriatric assessment as the evaluation and go forward to find out really these patients do not need treatment or they need treatment. And this is a practical series I am showing you, that in a patients of prostate cancer beyond 80 years, everybody will say, just wait and watch, we don't want to do anything. But if you have a life expectancy of 5 to 10 years, again, wait and watch in this population. Less than 5 years, again, wait and watch. So it is a very age bias that we are facing in the treatment of geriatric oncology. Now, something which all of you must know, and which has been very much highlighted in geriatric care, is the comprehensive geriatric assessment, which is a multidisciplinary diagnostic process which is intended to determine a frail elderly person's medical, psychosocial and functional capabilities and limitations, both. You see the flip side, you see the positive point also, in order to develop an overall plan on the treatment and the long-term follow-up. Rubenstein in 1982 gave this beautiful definition of CGA, and we all of us use it. What are the components of CGA? I have discussed this comorbidity. I have discussed the difficulty of polypharmacy because of altered pharmacokinetics and dynamics. I have discussed about the functional status of the two ladies was different. You can use ECOG performance status, you can use Karnofsky performance status. Cognitive function, Dr. Shamol Das has already highlighted a lot on that. Social support, which I think perhaps is most important in a country like India, and of course quite often forgotten but very important in developing countries, is the nutritional status of these patients. So these are the composite comprehensive geriatric assessment, and in a series in 2007 it was shown that in cancer patients, in around 7 studies where they underwent meta-analysis, the basic activities of daily living were impaired in around 31 to 86%. Instrumental activities of daily living, taking the telephone, putting on the geyser, lighting the switches, then seeing the television, all these were impaired in 26 to 52%. Then of course depression was very common, 40% in some series, cognitive dysfunction in 25 to 50%, and polypharmacy was very common. Most of the patients took a mean of 6 medications. So this is the importance of doing a CGA. Very important in public health is, we talk about cancer screening, but do they really benefit the elderly population? So when to stop? Because we know when the benefits outweigh risks unnecessarily, we don't want to continuing it. So what is the benefit in the increasing age? Is the risk more than harm? Is the risk the harm more than the benefit. So that's why there are some guidelines, like you don't do a mammography after 70 years. Useless. You don't do a cervical pap smear for screening beyond 70 years. So these are some public health data where screening has not really been effective if you do them in a very elderly population. And these are some of the guidelines which you will get in the internet. American Cancer Society, Canadian Task Force. So a lot of them, not all of them agree with each other. They do disagree. But in general, they agree that in very elderly population, it is useless to do. And even the prostate cancer, which is a very slow growing tumor. So if you start screening for prostate cancer, say beyond 75 years, anyway these patients will have a normal, near normal life with the prostate cancer. So for that, screening is not routinely recommended in the geriatric population in some of these task forces. And the last part of my talk is the elder specific clinical trials. They have not been tried. So it is time, I think, students and clinicians and public health workers, when you all be motivated to answer these questions, that is the safety and efficacy of certain drugs different in this geriatric population? If we use less toxic regime, low dose regime, are they as effective? That means non-inferiority compared to the standard of care. Are we really depriving them, or we should have a different protocol to manage the cancer patients who are elderly? So for that, we shouldn't do on an individualized basis. I feel I should reduce the drug by 70%. Somebody feels by 50%. So this is very ad hoc. What we need is, we need evidence. So we should have trials which look into this. Even with trials, there is so much of discrepancy. Since you are not oncologists, you need not know this, but I would try to tell you that in lung cancer, a lot of trials show benefit in the elderly, whereas in, say, breast cancer, they don't show that chemotherapy benefits the elderly that much. Head neck cancer, they show that very minimum benefit. So even with trials, there is a lot of discrepancy. This was a very interesting data where we all of us participated. This was from Tata Memorial Hospital, Mumbai, which is the key center like MSKCC in USA. We did a national data on healthcare providers. We sent questionnaire to a lot of healthcare providers. We found out the knowledge, attitude and practice of what they felt about this vulnerable growing population. 51% oncologists said they didn't discuss any evidence with the patient. They just did it ad hoc, or they were too demotivated. And 28% only included them in clinical trials. And they said that even with including them in clinical trials, we had evidence in only 8%, and 92% we didn't have any evidence of what we recommend. So I think, ladies and gentlemen, we should all contribute by doing evidence-based medicines, setting up clinical trials in this population, and really looking into on a very constructive way, not in an ad hoc, individualized approach. This is a small series which I wanted to show before I wind out. The morbidities in my series was 45%, advanced stage in most of the patients 75%, abandonment or refusal. Just once you tell them, okay, you have cancer, immediately they will leave your clinic. Okay, it can't happen, or even if it happens, but I've lived my life, they don't want to listen to anything more. So this is another 15%, and most of the patients, they end up getting some form of palliative radiotherapy alone. Not much of treatment is taken up by them, especially in those beyond 75 years. 65 to 75 years, yes, some of the patients do discuss, do take medicines now, do take radiation, they do standard of care surgery. But 75 beyond, our experience has been quite difficult. So to summarize, cancer disproportionately affects the older patients, older adults, in terms of the incidence, in terms of the comorbidity, mortality. The problem of older cancer patients is what I've written in the middle: comorbidity, functional disability, a lot of polypharmacy, altered pharmacology that actually impact all aspects of oncology research and practice. There is a lot of age bias. I have told you details on the age bias. Evidence to treat them has been very, very limited. So much has been the emphasis on evidence that geriatric medicine books are coming, new editions. year, but hardly any evidence on oncological practice in geriatric population, and we really need them. Before I end, it is your attitude which is most important. You can view this as two elderly men and women who have given up and they are at the end of their life, but you can also view them as an opportunity of young people inside them. So don't have bias, look in a very critical way, take up the challenge and then proceed. Thank you all for the very patient hearing.
Thank you, Dr. Kaur, for your excellent presentation and giving us an overview.
To the CGA, the suitable patients you should include in the trial. Then only you are justified. No? If you have a frail patient, you have a functionally KPS 2, why should you include them in the trial? So you should have a very comprehensive approach to including elderly in the clinical trial. Number 2, this is absolutely biased that you think that radical surgery is not possible in the elderly. In fact, radical prostatectomy, especially robotics, is doing very well in the elderly. So we shouldn't have this bias. We should try it out. Clinical trials are meant to create science. If you don't create science, science will never stop. It will get created. Yes.
Ma'am, when these elderly patients are diagnosed of cancer first time, should we inform the patient about his or her illness?
Okay, this is a very social question. As you are correct, most of the times the patient's family members come inside the clinic first and in a very soft voice they say, my mother doesn't know, my father doesn't know. So breaking bad news is an art which you develop with your practice. As oncologists, the first time an elderly enters, if you look very perturbed and very tense, very serious, then finished. He will not come anymore. But if you look very realistic, very normal, that what has happened to you is something that can happen to all of us, then it is easier to motivate them. So breaking bad news is a topic by itself which you need to understand and which you develop as you do in your practice. What we do is in the first sitting, maybe no, we behave very normal. We tell them these are the tests you go and do and I want to know what really has happened to you. Now when he visits an oncologist, he's not a stupid one that he will not understand. His family members are actually stupid who wants to deny him the right to knowledge. So what we do in the first setting, we are very normal. Second setting, I show that it is a serious condition and he should be very serious about it. And in the third setting, when he himself starts asking questions, I tell him, okay, you have got a tumor, which I might operate, which I might treat medically. And you know, gradually he becomes our friend and he starts accepting it. But yes, one time immediately telling the answer may not be suitable in a lot of patients. Some of them, yes. So it's an art of medicine, not the science of medicine. Yes, Tapusha had asked a very important question, palliative care. Now, this is again an age bias. We shouldn't think palliative care is only for elderly. Palliative care is also for young cancer patients. Palliative care actually is two things. One is end of life care and number 2 is when you don't have any cure, you can palliate a lot of his problems, his discomfort. So that is equally applicable to adults and to geriatric population. In geriatric population, why he is stressing on palliative care is unfortunately, people come forward in a very late stage. They don't want to come forward. That's why in most of the cases you may not be able to offer any cure. You have to palliate. Never think palliative care is negative. It provides comfort to the patients. It takes care of his symptoms. And 1/3 of our population who come with cancer actually can be offered only palliative. And we have palliative care units in our city, have excellent palliative care units in India. Some of them are completely free of charge. So this is a concept which is developing. And last thing which I would like to tell you, don't think morphine is the last medicine. This is very common amongst doctors also. Leave alone patients and family. Morphine, okay, that means last, everything is finished. You check, sign the check, give us all the bank balance, something like that. No. Morphine is the best cheap analgesic that is available and you should utilize it in cancer patients. Thank you.
Thank you. Thanks a lot. place in California. He is injured in rheumatology and he is a rheumatologist at national level. Dr. Shorkar will speak on last chapter, very last chapter, musculoskeletal disorders in the elderly.
Thank you, Dr. for the kind introduction. Thank you for giving me this opportunity to present to you all. Now, my group is to talk on musculoskeletal disorders in the elderly. It's a very important problem. There is a steady increase in the aging of our population, and according to this latest census 2011, percentage of population above 60 years in India is about 8%. And this aging is associated with some biological changes leading to increased risk of morbidity, disability, and even death. Now, our main challenge is to identify these morbid conditions early and ameliorate them accordingly. Now, my agenda of the talk will be magnitude of the problem, then I will talk on quickly one musculoskeletal examination, how to perform very quickly. Now, cause of this musculoskeletal pain, common musculoskeletal disorders and their management, and some atypical presentation in the elderly. Coming to the first one, the problem, around 50% of elderly are being treated by their doctors for musculoskeletal problems. And bone and joint disease are the most common cause of disability in elderly, compromising their quality of life. Now, in a recent survey, about 25% of elderly above 65 years of age use NSAIDs for their musculoskeletal problem, and this may endanger them to GI bleeding, which are often called crank, and even acute kidney injury. Now, the pain may be directly from the joint or from the surrounding tissue, muscular tension, or it may be referred pain, like a knee pain referred from the hip, or the sciatic pain from the lumbar spondylosis, like that. Now, a simplified examination protocol is the GALS, that is the gait, arms and hands, legs and feet, and spine, and active and passive movement of the individual joints, and swelling and tenderness of individual joint, because there may be arthralgia. Arthralgia means just pain. Whenever there is swelling and tenderness, then we call it arthritis. So there is a difference between arthralgia and arthritis. Now, what is this problem? There can be broadly divided into four groups. The bone aging, that is particularly osteoporosis and osteomalacia, sometimes associated. Then aging of the articular cartilage and joints, which is a degenerative disorder. Then inflammatory arthritis is developed, including some connective tissue diseases, which is rare, like SLE coming in the elderly. And some neuromuscular diseases in the elderly, like inclusion body myositis, some Eaton lumbar syndrome. Now, coming to osteoporosis, which is very common, actually in fact the most common problem in the elderly. We know that there are three phases of bone mass changes: growth up to the closure of the epiphysis, when about 90% of the bone mass is deposited. Then there is the next phase is consolidation up to mid-30s, when some increase of bone mass takes place. And then involution, which starts around 35 to 40 years and is accelerated by menopause. Now, the WHO definition says it is a skeletal disease characterized by low bone mass due to parallel loss of both bone mineral and matrix, and associated with increased risk of fracture, often after minimal trauma. It is somewhat genetically predetermined and related to declining osteoblast function. And about 50% of women and 20% of men have osteoporosis of the spine and femoral neck after the age of 50 years and likely to get a fragility fracture. Now, our Indian data, which was published in 2013, they put it 36 million of osteoporosis. Now, the peak bone mass, it is about 30% higher in men and 10% higher in blacks. And this is genetically predetermined. And this is caused by, this loss of bone mass is caused by an imbalance between bone resorption and bone formation, which is taking place all the time. And osteoporosis may occur in patients with the normal peak bone mass if there is excess of resorption, as in steroid induced or due to drugs like dilantin, like that. Now, severe osteoporosis with fracture occur in persons with low peak bone mass and increased resorption, like women taking rheumatoid patient taking glucocorticoid. Now, the BMD in Indians, they may be different from the white. We don't have very good data, but in a data published back in 2003, and there are other data also that are published by Olina Institute. It was saying that the healthy Indian armed forces with normal bone and mineral lab values, there was 30 to 50% patient men were osteopenic, and 14 to 32% were osteopenic. Now the clinical features are almost nil, and it is diagnosed after a fracture has occurred, like stroke after hypertension. And usual presentation is low back pain in crust fracture, abdominal protrusion due to loss of trunk height, or fracture of forearm, femur, or metatarsals on severe trauma. Diagnosis is done by DXA scan, and scoring are two types, that is T-score and Z-score. We all know that T-score less than minus 2.5 is osteoporosis, and between minus 1.5 to minus 2.5 is osteopenia. Now this is the whole gamut of investigation for osteoporosis. Plain X-ray may be done. It shows only radiolucence, but a specialized digital X-ray, that is radiogrammetry, sometimes is useful, but it's costly. Very innovative is a quantitative ultrasound bone scan of the calcaneum. However, the gold standard is a DEXA scan, and this quantitative CT is useful in some particular cases like diffuse idiopathic skeletal hyperostosis, where there is high osteophyte in the lumbar and thoracic spine. But it has a disadvantage of high radiation. And this serum chemistry, this serum calcium, phosphates, etc., they are for the other diseases like hyperthyroidism. And this bone marker of resorption and formation are mainly applied for monitoring therapy, particularly with teriparatide. Then coming to these two scores. Now by definition, this T-score we all know, but the International Society for Clinical Densitometry, that is ISCD, they recommend Z-score, because this T-score compares the big bone mass in young adult of the same race and sex. But the Z-score compares the individual BMD of two age-matched population. And Z-score less than minus 2 is taken as an osteoporosis. Now, and there is a new one, that is a track score, which was WHO has recommended is in 2008, and it can be downloaded by your FRAX calculator. Now, this is a diagnostic tool to evaluate the 10-year probability of osteoporotic fracture of hip, spine, wrist, and humerus. It includes the clinical risk factors for osteoporosis like age, height, weight, history of fracture, steroid use, and other causes of secondary osteoporosis like rheumatoid arthritis, whether patient is taking alcohol, particularly more than 3 drinks per day, and smoking, heavy smoking, current smoking. These factors are added to the femoral neck T-score, and the FRAX score is calculated. Low score is less than up to 10%, 10 to 20% is medium risk, and more than 20% is, and if there is a history of fragility fracture or T-score is less than minus 2.5, is a high risk FRAX score. Now this is a an X-ray of lumbar spine with osteoporotic crust fracture. Similarly, this is the MRI of the dorsal spine, where you can see one is the old, and this is the new one, new crust fracture with increased signal changes. Now, who are the candidates for treatment? Patients with hip or vertebral fracture, patients with BMD T-score of less than 2.5, then post-menopausal women with increased TRAX score. Now, management guidelines are non-pharmacological, like exercise, calcium, vitamin D, balanced diet, and drug therapy, selective estrogen receptor modulator, that is raloxifene, bisphosphonates, there's the main treatment, and they should always be given as a first-line drug. Calcitonin, particularly effective as a nasal spray, it is available for vertebral, and it has got an analgesic effect also. Then strontium ranelate, teriparatide, and one monoclonal antibody against the Rangs ligand. Now, this is the elaboration, that is this bisphosphonates, they inhibit the osteoclast mediated bone resorption. Raloxifene acts like just estrogen, with the good effect of estrogen minus the bad effects. Calcitonin inhibits the osteoclast and has the analgesic effect. Teriparatide, of course, is a very good drug, particularly for the vertebral fracture, but is costly. Dose is 20 microgram, and it should not be given for more than 18 months, because there are data in animal that when given for more than 18 months or 2 years, it may cause osteosarcoma. Other drug is denosumab, which is not available in India. It's a Rank ligand antagonist. Strontium ranelate is also not available, and this is a very new drug, Odanarcatic, and this is the cathepsin K. This is also a tyrosine kinase blocker. Now, coming to osteomalacia, seen in elderly, particularly in women, due to reduced sunlight exposure and decreased vitamin D level. It's a very common problem. Elderly patient coming with aches and pains all over body, always do a vitamin D analysis. And there will be also proximal myopathy, which widening gait and features of latent tetany. And the X-ray may show hypertrophy of the intervertebral disc, characteristic user stone, and this is the user stone. Seen also in the pubic rami, then scapula, head of the humerus. Now coming to the degenerative, that is the osteoarthritis group. Now the lipid content of increases, and the proteoglycans are altered, and the protease activity increases. And there is also sometimes deposition of CPPD crystal in both the hyaline and fibrocartilage. There are also the major synovial joints mobility decreases, about 20% in the knee and 60% of the hip movement. Now, it is not a single disease, but a manifestation of joint failure showing positive correlation with age. Weight-bearing joints are mainly involved in decreasing order from knee, hip, lumbar and cervical spine, then shoulder, wrist and elbow. Now, apart from age, other mechanisms are hereditary pre-existing joint disease like rheumatoid arthritis or other connective tissue diseases, previous trauma and CPPD crystal deposition. Now, according to an Indian study, the prevalence of knee osteoarthritis among the slum dwellers of Delhi, aged 60 years and above, was around 40%, and age more than 70 years, and females are found to be significant risk factors. And another study from Chandigarh correlated osteoarthritis in the geriatric population with age and also with BMI. And it was found that in the age group of 65 to 74 years, it was around 50%, and in 75 to 84, it it was about 64%, and above 84 years, it was almost 100%. So prevalence also increases with increasing BMI, and on patients with very high BMI, like 30 to 39, it was almost 88%. Now, the characteristic features, the joint pain, stiffness, deformity without signs of inflammation. There may be presence of evidence node in the distal interphalangeal joint and Bogart's node in the proximal interphalangeal joint. Signs of inflammation may occur due to this crystal deposition and loose body or trauma, especially in the knee joint. Rarely, a polyarticular osteoarthritis with Bogart node, that is in the PIP, may be misdiagnosed as rheumatoid because many elderly persons are rheumatoid factor positive, low titer. And we may find a Baker cyst which may be palpable in the popliteal fossa, and sometimes it may rupture and may mimic venous thrombosis. And patient may be given without clinical judgment, may be given low molecular or heparin. Now this is a normal joint and this is the osteoporotic joint. Again same. Then what are the subsets of osteoarthritis? There are 4 subsets. One is the nodal generalized varieties, seen 10 times more often in middle-aged elderly, particularly obese women. And it is characterized by DIP and PIP involvement, Heberden's nodes and Burkhart's node, and there is sometimes familial clustering. One variety is erosive osteoarthritis with involvement of both PIP and DIP, and first carpometacarpal with florid inflammatory signs and sometimes erosion. And these patients sometimes may be misdiagnosed, and sometimes they 15% may evolve into seropositive rheumatoid. There is another variety, that is the isolated knee osteoarthritis, very common in female, particularly diabetic female. And this lumbar spondylosis and cervical spondylosis is a variant of spinal osteoarthritis. And 2 important, that is the DISH, that is the diffuse idiopathic skeletal hyperostosis, which may be misdiagnosed as ankylosing spondylitis of late onset, and ossification of the posterior longitudinal ligament. They are the variant of spinal osteoarthritis. You can see here the erosive osteoarthritis in one patient. At the DIP, there was joint space narrowing and also subchondral sclerosis, and there is also soft tissue swelling. Now, this is a classical X-ray of this. The contiguous 4 vertebra osteophytes, floic osteophytes are there. Now, treatment, mostly lifestyle modification, quadriceps strengthening exercise, pain relief, particularly we should not go for NSAIDs, but if at all necessary, then we should go for the COX-2 inhibitor, which are friendly to the stomach, like ketoticoxib. Glucosamine and chondroitin sulfate are sometimes helpful, otherwise intra-articular hyaluronate. And steroid if there is inflammation. And if there is a extensive CBPD crystal formation, colchicine sometimes is very helpful. Now coming to rheumatoid. Rheumatoid presenting for the first time in the elderly has a rather benign course. There is no female preponderance, synovitis is more prominent, deformities are rare. Onset is sometimes abrupt, explosive, with systemic features, and 60% have cellular involvement. Rheumatoid factor is in high titer, but there is good prognosis because it's a common teaching that rheumatoid factor very high, there is a lot of extra-articular manifestation, but this is the exception in the elderly. Now, there are 4 subtypes. One is the seropositive erosive variety. It has got nodules with nodule and predilection for small joint involvement. There is persistent synovitis. Another is seropositive anodular. There is no nodule and there is no erosion also. and it is not polyarticular but oligoarticular, that about 4 or less than 4 joints are involved. Then another is seronegative, anodular, non-erosive, non-progressive, with prominent stiffness of large joint involvement and marked response to low-dose steroid. And very rare one is widespread bony ankylosis, just like ankylosing spondylitis. HLA B27 is negative. There is no SI joint involvement. Now, SLE. SLE in the elderly is rare, but when it occurs beyond 50 years to 65 years, around about that age, its prevalence is about 15% of all SLE patients. Arthritis, fever, serositis is very common, and also Zika syndrome. Raynaud's phenomena may be there, and lung, that is particularly ILD, interstitial lung disease, is a common presentation. But the skin manifestations and lupus nephritis and neuropsychiatric are less common, and due to this insidious onset, it may be very difficult. Most of the patients come with polyserositis, ascites, then pleural effusion like that. And in their diagnostic workup, anti-TSDN is frequently negative, but the rheumatoid factor is positive, and this Rho and La, that is SSA and SSP, are positive, which are actually diagnostic of Sjogren's syndrome. Now, another important is polymyalgia rheumatica. It is a actually not very prevalent in our Asian population, like in the West, but we must have a mindset to diagnose them. It is closely related to giant cell arthritis, because about 30% patient may have concomitant giant cell arthritis with headache, claudication of the jaw, sometimes with transient blindness, even stroke rarely. Average age is 65 years and beyond. There is painful stiffness predominantly affecting the proximal limb girdle and the axial muscles. Sometimes there is synovial swelling, especially of the hand, giving a sausage finger, that is dactylitis. And there is profound morning stiffness. Patient may be bedridden till late in the morning, and the inflammatory marker, that is ESR and CRP, is elevated. And the main diagnostic point is there is prompt response to low-dose steroid, 10 to 20 milligram. If there is no response to steroid, then we have to think of other diagnosis than polymyalgia rheumatica. There is another syndrome, unique, RS3PE syndrome. That is a remittent seronegative symmetrical synovitis with pitting edema. It is an uncommon disorder, primarily affecting the metacarpophalangeal and wrist joint as well as subtalar joints, first described by McCarthy late in 1985 in farm workers in California. There is a marked synovitis giving a sausage finger and sometimes a gloved appearance of the hand and feet with pitting edema. Rheumatoid factor is always negative, and this condition usually remits with a low-dose steroid or hydroxychloroquine. Sometimes it is a spectrum of the spondyloarthropathy, particularly reactive arthritis, post-diarrheal or after fever, particularly viral fever like chikungunya fever. In many cases, it may be associated with malignancy, as like we had a patient which he published, a 40-year-old female with thyroid tumor of the left breast. The RS3P occurred along with the thyroid tumor. It resolved spontaneously after resection of the tumor. Patient was all right for about 3 to 4 years. Again she came, after 1 year, there was a recurrence of this thyroid tumor, and then she again had this RS3P. Then chemotherapy was given, and then was resolution of the RS3P. This is the thyroid tumor of the left breast. Then this is the picture of the RS3P, pitting edema and diffuse synovitis. There is no erosion in this case, only synovial erosion. And after this chemotherapy, there was resolution. Now, there is another important subtype, category, that is a paraneoplastic musculoskeletal syndrome, and they can precede or follow the malignancy. Lymphoproliferative disorders solid tumors, particularly lung, colon and ovary, are more important. And in Indians, nasopharyngeal carcinoma. And sometimes patient present with dermatomyositis and then amyopathic dermatomyositis or polymyositis. Another variety is carcinomatous polyarthritis. It is also very not uncommon. And there are also cases of atypical polymyalgia rheumatica, particularly with renal, lung, colon and cancer, and also multiple myeloma. The diagnostic criteria in most cases are prominent constitutional symptoms. Apart from this joint symptom, the high fever, high CRP, ESR, and absence of response to glucocorticoid, which is very unusual for other, arthritis. Now, this carcinomatous polyarthritis, there is a temporal relationship between arthritis and malignancy, the late age of onset of arthritis. There is asymmetric joint involvement. Lower limb involvement is more important, sparing of the wrist and hand. There is always an explosive onset and remission of with the treatment of this cancer. There is absence of rheumatoid nodule and rheumatoid factor, and mostly associated with breast, colon, lung and ovarian cancer, and also some lymphoproliferative disorder like lymphoma. Now coming to the last slide, that is neuromuscular disease, inflammatory myopathy or polymyositis, rare in old age, but about 9% may present over 60 years, and these late presentations are mostly neoplastic. Inclusion body myositis, as I said, may be there. Hyperthyroidism in the elderly often presents with myopathy and involve Peter Lambert syndrome. And so the last slide. And so to conclude, musculoskeletal disorders are among the most common problem affecting the elderly. Osteoporosis is by far the most common with fracture, and adequate calcium and vitamin D and protein supplementation along with physical fitness exercise will go a long way to alleviate this sinister problem. And elderly presenting with inflammatory polyarthritis should always be screened for malignancy. Thank you for patient hearing.
Thank you, sir, for your great presentation. Here, one question. Must take some time, but there, so one question.
Is there any question? No? Okay. You mean treatment or? I don't know actually, there is no anecdotal report also of using quinine. Where are you ready? Quinine. How does it ever? I don't know.
Quinine could be used for muscular cramps or nightmares.
Yeah, quinine is used for muscular cramp in the elderly. It's a good drug. In lower doses, not. Quinine is available. Quinine is available.
So you have to end here. So thank you, sir. Thanks a lot.
Will you please open my presentation?
Got one medical question. We'll speak on immunization for the elderly. Even the geriatric is now and we will speak on that.
My dear friends, my colleagues, my postgraduate friends, he is the President of Indian Public Health Association, my long-time friend, and a key person behind of this 14th World Public Health Congress. Good afternoon to all of you. And now, immunization for the elderly. Time is very restricted. 1:15 is the lunch time. I've been told to finish by then, by that time. Let me see, I will try my best. Now, this presentation, this is the topic given to me is for the elderly, but I have extended it to adult immunization, because elderly in a sense is very restricted. Adult means post-adolescence, 19 years plus. I will deal with the issues of immunization in 19 years plus, that particular population. And I will try to identify certain facilitating factors because we know the successes of childhood and adolescent immunization in pediatric age group. Now, what facilitated this? And I will also deal with the key areas, the strategies or recommendations of WHO Global Vaccine Action Plan 2011 to 2020, the decade of vaccination, why adult immunization, principles of immunization scheduling, particularly in the context of age scheduling, current guidelines, developing countries. Now, immunization schedule is always country specific. Program is always country specific, depending on the particular epidemiological or disease burden situation in the respective countries. We will discuss about United States, the recommendations, the guidelines they are following presently. And lastly, the Indian scenario I will discuss in this presentation. Now we started, this was the situation you can see in the top left corner is a go-down filled with influenza patients, hundreds of influenza pandemic, 1919, 1920, the polio, paralytic polio, tetanus, the encephalitis. Now, we started with this, Edward Jenner, perhaps the first experimentation with vaccine. And we have come since then a long way, long way. So there are overwhelming evidence of successes by vaccines, smallpox eradication, paralytic polio, almost near 100% reduction. And some may raise the question, these are well-known facts. Why repeatedly telling about these successes, these great triumphs? I think this should be told repeatedly in all the forums of public health because we never hesitate to tell repeatedly about India's win, World Cup cricket win of 1983 every time. We don't hesitate. Why should we hesitate here? Because these are encouraging facts. Not only polio or smallpox, if we look at many of the diseases, you can see the figures. These are figures from the United States. Those figures for our country is not always readily available. You can see the middle column, the year of vaccine introduction. And you can see almost all diseases, starting from poliomyelitis, diphtheria, measles, rubella, haemophilus influenza, B, more than near 100% reduction is disease burden. That is the evidence of reduction. That is the evidence of success. Now, the question is what facilitated his success? Now, child survival, it is a global commitment. All the national governments, global community, international agencies are committed to child survival. It is included as a part and parcel of the country health program in most of the countries. It's a policy decision of all of the countries to ensure child survival. That is and that leads to very strong international cooperation. And that leads to technical and funding support for organizing and implementing country program, research and development in the field of vaccine logistics, operational research to identify gaps and deficiencies in the program implementation and taking appropriate corrective measures. System strengthening. If we think about immunization, even in a country developing or resource poor setting like our country, we have, at least in immunization, we have developed a very strong system. There is an excellent, extensive network of delivery points, immunization delivery points. We have human resource deployed at all levels, starting from community to sub-center to PSC to medical college. We have trained manpower. We have a very strong culture and vaccine logistics management system. We have been able to develop the supervision and monitoring mechanism and demand. Yes, it is not only the question of supply. In public health program, demand generation is an important issue, and perhaps throughout the world, in all the countries, even poorer countries, this is one program, immunization program, where there is sufficient demand. People ask in my clinic, in my departmental clinic, if there is a vaccine is not available, people ask, demand the vaccine. Why hepatitis B is not available? Why JE vaccine is not available? So that is one program where sufficient demand has already been generated. And availability and accessibility has been ensured to a great extent. I can say it is 100% because we have delivery points. starting from community outreach sites at Anganwadi centers to highest level tertiary medical college institutions. We have immunization session sites everywhere throughout the country. So this system has been developed, and we know information is strength. Information is very important issue for designing any program, because we have plenty of published data on disease burden, all vaccine preventable diseases, particularly childhood disease. We have plenty. If you go through any journal, scientific journal of public health or pediatrics or even medicine, you can find some article on certain vaccine preventable diseases or coverage evaluation. There are plenty of national and international publications, plenty of clinical trial, field trial data, serological data. It is very important for introduction of new vaccines, coverage evaluation data, data from operational research, and surveillance data, by which we can show the impact, the result of vaccination, the results of the program. So we have this information, that is our strength. Now so these are certain factors which facilitated the successes of immunization program, particularly childhood age group. Now, few lines about the WHO Global Vaccine Action Plan. The vision, one of the vision, there are 6 strategic areas. That one strategic area vision is a world in which all individuals and communities enjoy lives free from vaccine preventable diseases. All is very important. By all the mean, to all throughout their life course. By all the mean, to all who are at higher risk in every age group. So when we say adult immunization, there are two situations. One is routine adult immunization, and another is certain recommendations for adults at higher risk of suffering from certain vaccine preventable diseases. That is very clearly mentioned in the vision of the Decade of Vaccine WHO Global Vaccine Action Plan 2011-20. Now, let the focus, the build, it is built on success of childhood immunization, this adult immunization, and recognition of the burden of adult vaccine preventable diseases. It is already recognized. Now, why adult immunization? Next issue. Now, we know that immunity wanes over time, and aged are more susceptible. Certain diseases, many of the diseases which are not that serious or life-threatening or complicated or milder form in younger age group, like influenza, like pneumonia, like herpes, like chickenpox, may be fatal, complicated in older age group. That is a very important issue. So there is need to boost the immunity in older or adult population. Age shift, another epidemiological factor. With widespread childhood immunization against diphtheria, against tetanus, against pertussis, in many diseases there is age shift. We are finding these diseases mostly in adult population. There is one paradox called pertussis paradox. In 2004, the pertussis immunization coverage is very high, very high. But in the same year, there were 25,287 pertussis cases, of which 15,000, more than 15,000 were among adults. So that's a very high rate among adults, and that signifies the importance of age shift. There is a shift in epidemiological situation. We have to take into consideration, think about or review the adult immunization policies. And another point is considerable vaccine preventable morbidity in the productive age group of our population, that is high hospitalization rate, diminished quality of life, loss of productivity, economic burden. All this must take into consideration, because it is highly rational to think about and revisit the adult immunization policies. Now, evidence. We need evidence. We need information about disease load among adults. Do we have that? For developed world, yes, we have. We will show some of the results, some of the disease burden situation in the United States in particular. But for India, do we have any national data? Say, for example, if I ask the question, how many elderly in India suffer or die from influenza and its complications? Do we have any nationwide data? We don't. Particularly when we think about diseases which need lab confirmation, While there are circulating serotypes change every time, every year, do we have that lab confirmed data? What are the circulating serotypes of influenza in India? Do the case load justify routine influenza vaccine in geriatric population? That has to be taken into consideration because it is related to vaccine efficacy, it is related to cost effectiveness. Whenever we are going to include anything in the country program, we must take into consideration all these issues, the cost component, the effectiveness, and that depend on the data on disease burden, mortality burden because of that particular disease. But we don't have nationwide data. Is our delivery system capable of managing this? Our delivery system, just now I was describing, we have excellent network of public health delivery points, particularly for immunization services. But is that system sufficient to cater to maybe adult population or geriatric population? Perhaps no. So our delivery system at this moment is not capable of managing this. We need resources, additional resources. So these are the factors. So we have a very limited data in fact. When you think about adult immunization, very limited data, only some local or institutional published data, national situation, we really don't have any idea. And data is evidence. Because to justify vaccine, we need evidence. To justify vaccine scheduling, at what age, which vaccine, at what interval, it should be given. That needs data, evidence. Vaccine efficacy and safety, we need evidence. Introducing new vaccines, like in childhood immunization, we have introduced second dose of measles vaccine in recent past. We have introduced Japanese encephalitis vaccines in endemic districts. We have recently, very recently, we are in the process of introducing pentavalent, which includes HIV, a new vaccine in our country program. But for adult vaccination, we need that justification. Program management, that requires, because it is program management, it is logistics management, managing whole program, that requires data, information, and evidence of impact, that is surveillance data. In the context of adult immunization, we really, data is very sparse. The scarcity of data is too much. Now, age of vaccination, we need this information. Specifically, to determine what should be the scheduling. Because optimal response to a vaccine depends on age of the recipient, immune status, existing immune status, type of vaccine, and past vaccination history. These are the factors which determine the response to a particular vaccine. And there are certain special situations. The earlier situations common to all, but there are certain special situations like immunodeficiency disorders, HIV infection, immunosuppressive drugs, hematopoietic cell transplant, and finally, the risk and severity of vaccine preventable diseases are much higher in this group, this immunodeficient individuals, and the safety and effectiveness of vaccine is also need to be examined, because the vaccine, particularly live vaccine, which is safe in an immunocompetent individual, may not be that safe in immunodeficient individual. That has to be examined. And role of immunoglobulins, that is passive immunity in such these situations, that has to be examined. So there are certain special risk groups like say pregnancy, chronic renal disease, end-stage renal disease, dialysis patient, cardiac disease, chronic lung disease, chronic alcoholism, chronic liver disease, diabetes, and IBD, intravenous drug users, MSM, healthcare personnel, travelers. These are the special groups. They require separate recommendations, separate data set to understand the situation there. So besides all adults, there are certain special group, special risk group. Now, let us see the VPD burden. As I told you, we have very limited data in India, but in developing world, Western world, some data. Say for influenza, in United States, they have more than 200,000 hospital admissions annually, 36,000 deaths, and more than 90% deaths because of influenza are in 65 years plus with comorbidity. This information is available there. So invasive pneumococcal disease, 2,000 to 5,000 meningitis because of Streptococcus pneumoniae, 40,000 Boston infections, septicemia, 150,000 to 300,000 pneumonia, or herpes, 1 million cases per year, These are all in United States. Serious debilitating pain, quality of life seriously deteriorated. Hepatitis B, 51,000 cases, 3,000 deaths, 95% in adults. So, human papilloma virus, 6.2 million new infections yearly, 11,000 new CSRB cases annually, 70,000 sexually active persons acquire HPV infection at some time. Based on all this information, in their country, they have this recommendation for adult immunization. You can see the yellow color denotes there is only one condition. If the age condition is fulfilled, vaccine should be there. Like say, influenza, 1 dose annually for all adults, 90 years and above, 19 years and above. For tetanus, diphtheria, pertussis, first dose, if not given in childhood, 1 TDAP, that is inclusion of pertussis, a single dose, followed by 10 yearly a single dose of TD vaccine. That is the recommendation for all adults. 1 dose of tetanus diphtheria every 10 years. If pertussis is not taken in early childhood, then 3 doses of pertussis at the beginning. Then varicella vaccine, 2 doses for all adults, 1 time. Human papilloma, 19 to 26 years female, 3 doses. Routinely, all women, 19 to 26 years. Zoster vaccine, routinely for people 60 years and above, a single dose, that is in yellow. Mumps, measles, rubella, 1 dose for everybody, but for women, 2 doses. So, these are the recommendations. Pneumococcal polysaccharide vaccine PPV 23, that is 1 dose for people, routinely for people 65 years and above. For some other vaccines like, say, pneumococcal vaccine, for earlier vaccination, that is recommended only for high-risk groups, those who are at higher risk, or some other comorbidities like COPD, like end-stage renal disease. Meningococcal vaccine, again, when there are other associated factors, that is recommended only for high-risk groups, not routinely for all adults. Hepatitis A, hepatitis B, all these vaccines are for high-risk adults, not for all adults. But they have certain recommendation based on the epidemiological situation, based on the information of disease burden in our country. Let us look at situation in our rapidly aging population here also. Our population is expanding, aging because of increasing lifespan. It's a rapidly aging population. But we really don't have any national guideline at this moment. What we have till date is one guideline recommended by one expert committee on adult immunization by Association of Physicians of India and the Department of Medicine at All India Institute of Medical Science. Now, what recommendation they have given? They have just considered the evidence and they have graded the recommendation accordingly. Evidence, different levels of evidence they have taken into consideration. Like, say, 1A, that means about that particular problem, we have systemic reviews or meta-analysis of several RCTs that is available. That is evidence level 1A. 1B, at least one RCT is there. Likewise, 2A, at least one well-designed clinical trial, not RCT, at least one well-designed clinical trial. 2B, at least one cohort study. 3, 4 descriptive study, 4 clinical experience. These are the levels of grading of evidence, and based on that, they have given certain recommendations that is also graded in A, B, C, D. Okay, without going further into such details, let us examine according to certain vaccines. Influenza vaccine, we have no data, as I told you earlier. So, no serosurveillance data on circulating serotypes, not recommended for routine use. No evidence to recommend even for the high-risk groups. Who are the high-risk groups? In the context of influenza vaccines, patients suffering from COPD or immunodeficiency, malignancy, renal disease, hemoglobinopathies, healthcare providers, people who are responsible for culling poultry infected with avian influenza. But even for them, data do not support routine use. in high-risk situation. Pneumococcal vaccine. More than 15 meta-analysis data published conflicting results on efficacy of pneumococcal polysaccharide vaccine in adults. Conflicting results. In API recommendation, that expert group recommends this only for splenectomy cases. 2 weeks prior to splenectomy, they have recommended this. And WHO latest published meta-analysis suggests in resource-limited setting like India, while there are many competing health priorities, the evidence does not support routine immunization of the elderly and high-risk population with pneumococcal polysaccharide vaccine. Clear, it is not recommended, considering the current availability of information. Meningococcal vaccine. Vaccination of all adults, not recommended. Low efficacy, short duration. It is only recommended for outbreak situation, and it is recommended as a mandatory stipulation for Hajj pilgrims. That is, those who are traveling to Saudi Arabia, for them, dose of meningococcal vaccine is mandatory because that is country requirement of Saudi Arabia. That is very restricted recommendation for this group only. Okay, meningococcal vaccine. But for one adult, not recommended. JE vaccine, as we know, presently we are giving 2 doses, one at 9 months, another at 16 to 24 months. And for late initiation, recommendation is 2 doses at 3 months interval within up to 2 years. If it is more than 2 years, within 15 years, single dose, JE vaccine. That is the current recommendation. And it is already ongoing in the program. But the question, as there is change in epidemiology, we are seeing more and more Japanese encephalitis cases among adult population. So, Government of India is actively considering reviewing the policy of JE vaccination in adult age group in the light of changing epidemiological scenario. That is under consideration. For TDAP, as I told you, for immunized with routine DPT in childhood, routine TD vaccine, only TD, every time. That is the recommendation. And those who are unimmunized, then 3 doses of TDAP followed by TD every 10 years. That is the recommendation for TDAP for adults in India. For all healthcare workers, it is required. Now, this is TT immunization schedule policy for adults. I am skipping this. But what the golden rule is, we must remember, because this faulty message has percolated to our population, to whenever there is a cut, whenever there is an injury, be it whatever be the size or nature of the injury, give one TT. People over the counter take this, and this is most erroneous, most faulty belief. We have to take into consideration whenever planning or administering tetanus immunization, we have to think about past immunization history. Then you have to decide whether a dose of tetanus toxoid, full immunization primary course, or a booster dose will suffice, or in this particular situation, tetanus immunoglobulin will have to be given to prevent tetanus. These are the things that has to be taken into consideration in adults. Hepatitis B vaccine, it is recommended for all unvaccinated high-risk adults. What recommendation I am referring to here is the recommendation given by expert group in India. That is immunocompromised household contacts of HBsAg carriers, chronic liver disease, chronic renal disease, dialysis patients, IDU and MSM of them. So all unvaccinated high risk group in India. Okay. But it is contraindicated in pregnancy definitely. Mumps, measles, rubella, single dose recommended for oral apps, as in Western world, as I have shown. For women and healthcare workers, 2 doses, if not vaccinated with these vaccines in childhood. Contraindications, obviously, pregnancy, acute febrile illness, severe immunocompromised. Typhoid vaccine. Now, typhoid live vaccine is available, 3 doses on alternate days. Avoid food for 1 hour, and also avoid, and that is very important information because they are taking the vaccine, but they have to follow certain norms, that is avoid antibiotics for 3 days before and 7 days after the vaccination. That is very important for typhoid. Okay. Now, recommendation. It is recommended for routine immunization in adults and up to 19 years. that expert group recommended this, but not recommended for adults, typhoid vaccine. Again, varicella vaccine. It is recommended only for post-exposure prophylaxis, not for routine use in adults. Only for post-exposure prophylaxis in certain high-risk situation, like pregnancy, something like that. Okay? And varicella zoster immunoglobulin is recommended where there is direct exposure to varicella or disseminated herpes zoster patient, pregnant woman exposed to patient. In that case, varicella zoster immunoglobulin is recommended. Now, let us summarize. Influenza, US, 1 dose annually, all adults. India not recommended. Tetanus diphtheria part 26, same recommendation, 1 TDAP dose followed by TD every 10 years, both US and India. Varicella, 2 doses, all adults, not recommended in India. Human papilloma virus vaccine, 3 doses, 19 to 26 years, same in our country also, recommendation. Herpes zoster, 1 dose for all adults, 60 years and above, not recommended in India. MMR, 1 dose for all vaccinated adults, yes, here also 1 dose for all vaccinated adults. Pneumococcal vaccine, 1 dose for all above 65 years of age, in the United States recommended, in India, not recommended. Meningococcal vaccine, all high-risk adults in India is not recommended, only recommended for hospital use. HBV, hepatitis B virus, only high-risk adults, yes, here also high-risk adults. HIV, in United States is recommended for high-risk adults, in India no recommendation. Typhoid vaccine, it is recommended 3 doses up to 19 years of age, up to adolescent, not recommended for adults. JE vaccine we have already discussed, it is recommended up to 15 years of age and it is under active consideration of Government of India. And ARV for rabies vaccine, everyone knows it is recommended for post-exposure prophylaxis. This is, in short, what is the situation ongoing in the Western world, United States, and here in India. Now, what are the challenges? Now, challenge we have already discussed. Number 1 challenge is we don't have any disease burden data at the national level to justify introduction of or routine use of vaccines, not only for routine use and also used in special use. That is very necessary. National policy is not yet there. It is still not a priority. Inclusion of country program, we need resources that has to be taken into consideration. It's a serious issue because all adults means it's a large demand. And people still are.
When this condition stabilizes a bit, before going home, we have to shift it to the subacute care. And discussion between acute care physician and subacute care physician, they decide when to transfer from acute care to subacute care. Usually, pediatric patients who stay in subacute care, they stay for 1 to 3 weeks and say up to 3 months. Who are the patients who need subacute care? Subacute care is one of the important models of geriatric care. And who are the patients or conditions which need transfer to a subacute care? That means after the acute care. Certain patients with geriatric syndromes like delirium, dementia, urinary incontinence. Then post-operative cases. Then patients with dreadful pressure ulcers, sometimes dying patients, and those patients who have got severe medical conditions like congestive cardiac failure, sepsis, etc. But they don't need ICU. They can be kept in subacute care. Then patients with a fracture who need long-term care, they go to subacute care. And the subacute care will also take care of the medication that has to be given, the dosing that has to be given. As you know, in elderly, the dosing is different and they may have complications with medication. So to adjust all these, patients may need transfer to subacute care before they discharge to home. Then wound care. And most important term in geriatrics is rehabilitation. That is the mother term comes again and again in geriatric medicine. Rehabilitation, that is most important. What are the contraindications for transfer to subacute care? Those patients who are severely ill, who need acute care, they cannot be transferred to subacute care. Because by definition it's subacute, not the acute. So severely critical patients, they go to acute care hospital, or in extreme cases, they are shifted to geriatric critical care. And those patients who will be discharged very shortly from the acute care, they also are not transferred to subacute care. They discharge directly from the acute care. And patients also waiting for urgent surgical procedures, they are kept in the acute care hospital, not in subacute. So these are the contraindications for admission to subacute care. What are the major components of subacute care? As you see, is medical part, they have a nursing part, again rehabilitation, and there are some financial and reimbursement aspects. That means they are covered by life insurance or the insurance, etc., which takes care of the payment. That is the important part of the treatment. This one elderly man having physiotherapy. So what are the sites of subacute care? Where do you provide the subacute care? They can be in geriatric ward of hospital, there will be special subacute wards of hospitals, or even in the community hospital setting, or in what we call a skilled nursing home. What is the staffing of subacute care? That means in geriatric medicine, the most important thing is that it is a combination of various problems. There are multiple comorbid conditions in the same geriatric patient. So generally they need a multidisciplinary team to take care of them. That is most important. Multidisciplinary team to take care of it. Now in geriatric OPD is ideally the patient there, so all the patient is in one OPD taking care of the patient. So orthopedic surgeon, the general surgeon, the physician, the physiotherapist, the gynecologist, all in one place. So it is basically multidisciplinary. Most important term. Geriatric medicine, geriatric patients are usually having multidisciplinary problems. So the team should comprise the various important persons who take care of the various disciplines. That means one first is physician, of course, the medical person, then the orthopedic surgeon or general surgeon. Orthopedic is very important in geriatrics. Then gynecologist may be required, a trained house medical officer, a skilled nursing staff. There are special nursing staff who are trained in the various types of what they have to do in geriatric medicine, so they can take care of the patients. Then physiotherapist, dietitian, most important, the counselor, and the social welfare officer. So you note the physiotherapist, dietitian, they are all very, very important in geriatric team which takes care of geriatric patients. The quality of subacute care that you provide depends on, is quite obvious, the trained nursing staff if they are good, the rehabilitation services, the palliative service, then of course good food, ambience, amenities like television and clean rooms, comfortable surroundings, they all help in the recovery of the patient. What are the important medical issues that might crop up during the treatment in a subacute care setting? First is, one important thing is pain management. Elderly patients are often subjected to severe pain for various reasons. They have some malignancies, they may have some orthopedic problems which can give rise to pain. And that is controlled with proper administration of opioid drugs. That is most important. Then another problem in elderly, what we call geriatric syndrome, is urinary incontinence, for which there have to be catheterization. So that may be required in some patients. Then feeding the elderly, particularly those who cannot swallow properly, particularly post-CBA patients. Suppose you want to use rice tube, they have to swallow, and that is very important for them. So you have to take care of the eating process, right? Proper administration of the food so that they can swallow the food properly, and avoiding the aspiration, which is very important. When falls should be prevented. Fall is a very important term in geriatric medicine. Patients are often, because of various extrinsic and intrinsic causes, they often trip and fall, and that causes injury to the limbs and cause fractures. So you have to prevent the falls also. And pressure ulcers are common in the elderly, we have to avoid them. And issue of medications is also important as a medical issue in the subacute care setting. Then outcome of patients in subacute care depends on the severity of illness, as you can see. The frailty of the patients. Frailty means when the elderly become dependent. They have sarcopenia, muscle mass is wasted, they have some hormonal changes, endocrine changes, they become dependent. Their muscles, grip strength decreases, they become weak and frail. That is called frail elderly. So the elderly patients who are frail and dependent, and those patients who have got severe illness, and the quality of care is not good, in those patients the outcome may not be good. So what are the outcomes of subacute care? It is obvious, some are discharged, most of them. Some remain, they cannot be discharged home. As you know very well, geriatric patients cannot be discharged home. They stay and stay and stay continuously, creating a problem for the doctors. Remain admitted as long stay patient. And some are after discharge, some are again re-hospitalized. That means from subacute care, they go to the acute care, back to acute care. And some of course die. These are the 4 types of outcome of patients in the subacute care setting. So when you discharge the patient from subacute care, when the patient becomes fit and stable, there is improvement in functional status. That means activities of daily living. That means toileting, bathing, dressing, all those ordinary things of daily activities that is required. They are called activities of daily living, basic activities. And what do you mean by the IADL, or the instrumental activities of daily living? That is little bit more advanced work like catching telephone, little bit addition, subtraction, all those things, they are called the advanced activities. So when they become a little bit more active in functionally with respect to ADL and IADL, they are fit for discharge. Another important thing is, as there was a lot of talk in the morning, there is improvement in the cognitive function, and dementia and depression are taken care of. Then you can discharge them. And proper discharge advice includes you have to write the medicines very carefully in the elderly. You have to advise some rehabilitation program in most of the cases. You have to advise regarding physiotherapy, and you have to suggest some environmental modification at home. That is most important because geriatric patients, as you said, are prone to falls. So we may have to advise in the discharge certificate that you have arranged for grab bars in the bathroom, arrange proper toilets, the room should be lighted up, there should not be clutter in the room, there should not be carpets with uneven edges like that, so that they do not trip and fall. So this environmental modification at home is very important. So suppose telephone should be within reach, within hand, so they do not stress like that and fall down, that thing should not be there. And the other, you have to hint on the stress on the multidisciplinary care. They may have to go contact all sorts of specialists for the multifarious problems after discharge. So we now conclude the subacute care, that is the very most important part of the most important model of geriatric care, subacute care, and now we pass on to the home care. So patients, acute care, better, subacute care, still better, discharge. If they prefer home, they can go to home. If there is a suitable environment at home, they go to. That is called home care. So what is home care? It is also known as domiciliary care. Domiciliary care means care of the elderly in the domestic setting. That means at home. It is actually a component of the community-based long-term care, or the CBLTC, and delivered by physicians as well as NGOs. That is home care. Treatment at home. Indications of home care. Who are the patients, geriatric patients, elderly patients, who will seek home care, who will be put to home care. Those patients unable to visit doctors' clinics or other healthcare facilities because of frailty, disabilities, poor mobility and dependence, they of course stay in the home. They like to stay in the home and they are treated at home. And secondly, as I have just said, after subacute care, if they are better, they are shifted to their home. Another thing is that they are unable to bear the expenses in other healthcare settings. So because of high cost, they want to stay at home to lower their cost of living, cost of expenses for the medications. The goals of home care. What are the goals of home care? The goals are the relief of symptoms and improvement of physical and mental status. It is all the geriatric medicine, physical, mental, physical decline, mental decline. All these will go pari passu. The detection of new illness or any recent deterioration and urgent treatment. And if the patient becomes bad at home, there is a complication, they have to be transferred to hospital if needed. And doctor who treats the patient at home must be very sympathetic to the patient's families and give support to the families and caregivers. That is most important. Types of home care, 2 types mainly. One is informal care, that is not paid, that is offered by patient, family members, friends, volunteers. Suppose family members means usually the daughter or son or spouse, they offer their help, they care for the patient, they are the caregivers. Sometimes if they are not available or they are reluctant to help, then friends, volunteers, and usually female subjects take the prime part in this. And they provide most of the part of the home care. That is informal care. Then the formal home care means paid, and they are often covered by health insurance scheme. It is offered by physicians or responsible professional bodies who come to the home and attend the patient. What are the models of formal home health care? One is physician house call. That is a very interesting program. It is not very well developed in our country. The general practitioners and the physicians, geriatricians who are a part of this house call program, they are called by the patient in emergency or for checkup, and they go to the house, they treat the patient, and they regularly follow up the patient's up. They are handled by physicians, nursing staff, etc. But it is not so well developed in our country. The physician house, it is a lucrative thing for physicians because once you treating a patient, you will getting calls regularly and income is flowing to you. So it is a lucrative thing, but it is not well developed in India. Or you can provide a hospital level care at home. These are the models of the formal home health care. So we finished subacute care, which is a geriatric model. We finished the home care, another model. Now we pass on to the community-based care. It is institution and community care. It is also a component of the community-based long-term care, CBLTC, and it is also multidisciplinary. So home care and community care, they are both taken together, but home care is different and this is only institution and community care. What are the goals of the institution and community care? To provide the optimal care, to restore and maintain function in the patient, maximize the quality of life, to increase the quality of life. Most important thing in elderly is to improve the quality of life. That is called improving the quality of life and preserving autonomy, maintaining safety of the patient, and providing comfort and dignity in the toilet period, rest period of life. And if the patient is dying patient or suffering from terminal illness, that also comes under this community care. What are the types of institution and community care? They are mainly of 6-7 types. One is mainly the assisted living facilities, ALF. They are actually sort of what we call the old age homes. In this ALF, it is meant for relatively independent elderly. That means elderly who are a little bit better off and are not completely dependent, they are put in this ALF facility. It is sort of elderly age group home or geriatric home or old age home, you say. It is a paid, they are paid, of course, it is a paid housing accommodation. And what are services provided in this assisted living facility? There is a 24 hours supervision in these old age homes. Patients have meals in a group dining room, so they have a brotherly feeling, they can talk and discuss things, they are even lively. The personal care services are offered to them and help is offered to them with regard to the activities of daily living. Medical management support is there, doctors are available to come and take care of them, provide medicines. They have also exercise, recreational and spiritual activities like dhyan, etc., so that they remain lively. And then laundry, cleaning service, housekeeping, and there is special supervision for persons with Alzheimer's disease and various disabilities. Then we have nursing homes. They are also another type of old age homes. Here there is comprehensive assistance for dependent people, those who are more dependent elderly. Those patients who have got cognitive loss, visual problems, delirium, they need a more concentrated and better care. For them, these nursing homes are there. So they also help with the activities of daily living. The care of incontinence during catheters is there. Maintenance of nutrition and hydration, that is most important. In elderly, the nutrition is most important. Unless you maintain the nutrition, you will suffer from all sorts of malnutrition, and that will decrease their immunity and will suffer from various types of diseases. So adequate food intake, adequate hydration, then take care of that so that do not they fall, and if there is a pressure ulcer, take care of pressure ulcer. Then behavioral symptoms, sometimes they are having some mental psychiatric problems, treat those psychiatric problems, and maintenance of psychological well-being. And if they are given psychotropic drugs, you have to take care of those drugs so that they are taken properly. Now we come to other types of institutional long-term care centers. Briefly mention a few. One is a chronic care hospital. For patients who need long-term care for weeks to months, suppose one is having treatment blood transfusion, for example, myelodysplastic syndrome, having blood transfusion regularly, aplastic anemia sort of thing. So these patients who have regular blood transfusions for them, or those who require non-invasive ventilation for them, these chronic care hospitals have been instituted. Then there are some skilled nursing facilities where patients are not admitted, but they are given training regarding certain things. For example, wound dressing, education about self-administration of insulin in diabetic patients like that. Then unskilled training in some places like, say, how to toilet, how to feed, how to turning patients in their beds, ambulation, not insulation, ambulation, etc. So the caregiver is advised regarding all these things so that they can take care of the patient at home. Then management of dementia also comes under this. Then you have a thing called respite care. It is also comes under the institutional long-term care. Respite care means the caregiver who is treating the patient for days on end, he may be having some stress factor. He is heavily burdened with the patient. He doesn't have rest. He himself becomes a patient. So to give rest to the caregivers, they need a break. So the patients are transferred for some time during the day, say to a chronic care facility of brief duration, a nursing home or a chronic care hospital. For during that time, the patient, the caregiver has a break at home. He can take some rest, and when the patient comes back to home, he can treat you better. Then there is a program, not in our country, it's in USA mainly. This program for all-inclusive care for the elderly. It is a day healthcare center in which insurance-eligible elderly receives comprehensive medical, hygienic, social, and rehabilitative care. So it is a sort of insurance dependent. They get money from insurance companies, and the elderly are taken care of in this space program. Then hospice service. It means service for those elderly with terminal illness. It is either institution or community-based, and the focus is symptom relief, symptomatic management, and a dignified death at the end. So this you can see in an institution where the people are taken care of in old age home. They're taking food together. They have a brotherly feeling, taking food, so they remain lively and alive, happy. Otherwise they will get depressed, which is a very common problem in the elderly. Now we pass to third level care, where subacute care, home care, the institutional community care. Then to talk about the acute hospital care. Those patients who have some acute problem, say SCBA or something like that, they go to the acute hospital admission. So that is, they say that elderly patients account for 1/3 of acute hospital admission. Study conducted in USA, 1/3 of all acute admissions are elderly. So they have in elderly, after the acute, those patients with acute problems, the elderly patients, they have a more complex hospital course and 5 times more mortality, obviously, than younger patients. And increased risk in elderly patients with acute problems are due to multiple comorbidity. That is most important. As I have repeatedly stressed, the elderly have multiple comorbidity and multidisciplinary treatment. That is most important. Then polypharmacy. The elderly are subjected to so many drugs. Number of drugs are there together which interact and cause all problems. That is called polypharmacy. Then functional decline because of aging, muscle mass wasting, sarcopenia, etc. Patients have got weak muscle strength, they can fall. That is called functional decline. Then cognitive impairment. As we discussed in the morning, with aging, there is some difficulty with cognition. Then social support dwindles in the elderly also. So all these processes lead to acute hospital admission. So this is obviously that's a list of the 15 most common conditions requiring almost all the admissions in an elderly setting. The heart failure is common, pneumonia, ischemic heart disease, cardiac dysrhythmias, AMI, COPD, stroke, osteoarthritis sometimes, and then for rehabilitation also, fluid electrolyte disorders, chest pain, UTI, hip fracture, and sometimes complication of medical device like pacemaker, etc., implant or graft, etc. And septicemia most important. These are the usual conditions which necessitate the elderly being admitted to an acute hospital care setup. So other acute factors are failure to thrive, falls, adverse drug effects, and change in mental status and frailty. These are the other factors which lead to acute hospital admission. Another thing in elderly is that they have often atypical presentation. Elderly do not present in the usual way. Say patient of pneumonia might come with the incontinence of urine or becomes drowsy, nothing else, but he is suffering from urine. So atypical presentation is very common in the elderly, and the treating doctor must be aware of this atypical presentation to detect the cause of the illness in the elderly. Then the screening of elderly who are admitted to acute care setup admission, the doctor has to communicate. Communication is always very important, particularly more in geriatric setup with the family and primary care providers. The family physician, the family members, they will provide the history. All medication list, usually a polypharmacy, big list of medicines, they have to be reviewed and seen without getting disturbed. And then the functionality to assess from ADL and IDL, and patients if they are frail or demented, that has to be screened also during admission to acute care setup. Some aspects of hospitalization acutely ill. That means there are some problems cropping up in the elderly patients who are admitted to acute care setup. One is delirium. Delirium is a very common thing we get in the wards. Elderly patients talking incoherently. That means they are not talking sensibly, and that is delirium. Suppose the elderly patient has been tied up or changed to a new place, you have delirium. He is having sepsis, whatever it is. There are thousands of causes of delirium, and that is most important, particularly in the acute care setup. And so prevention is important. Then, as I repeatedly said, immobility and falls. There are certain things can occur in high risk in acute patients, but preventable. Then nutrition has to be maintained. The nosocomial infections are common in the elderly. Suppose 10% they say develop UTI, pneumonia. Two common infections in elderly are UTI and pneumonias. Surgical site infections, the septicemia, diarrhea, etc. They can all occur and it is prevented. Then venous thromboembolism. And in susceptible patients, like patients who are lying down for a long time, they have to give anticoagulants or tourniquets, whatever it is, for the thromboembolism. Discharge from acute care. That means patients, when they are discharged from acute care, the doctor, attending doctor who is in charge of the acute care facility, treating the acute patients, they have to call the physician, the general physician or the physician who takes care of the patient at home. He has to be explained. Or if it goes to subacute care, he has to contact the subacute care physician either personally or over phone and explain them what the patient is having. Then awareness of patients and family is very important. And medication advice should be, it's very important. That should properly given and adverse drug effects should be avoided. And pending lab tests, sometimes the lab tests are pending, they have to track afterwards. Now we come to the last part of my lecture, the last item, last model, that is geriatric critical care. It is said that more than half of all ICU admissions are elderly. What are the risk factors in elderly which make them admit to critical care? Number one is the chronic vascular and metabolic conditions like hypertension, the type 2 diabetes, the acute coronary syndrome, the stroke, and again dementia. Then acute infections of the respiratory tract, urinary tract, skin and soft tissue. Then the cognitive impairment, functional disability, and psychological factors. All these factors lead to acute admission critical care unit. Then immunodeficiency and compromised physiology is also another factor. As you know, there is a term called immunosenescence. When one grows old, the immunity declines and one is prone to infections, and that may lead to admission to critical care unit. Lastly, general principles of geriatric critical care are, some points have been laid down, that is, the elderly with life-threatening conditions should be managed as per standard protocol. Protocol as usual, as it is in critical care unit. Age is of most important and prognostic importance also. More the age, the worse is the prognosis. Useful medications in optimal dosage are to be prescribed and adverse drug reactions avoided. Assess the functional status before and after therapy. And discuss prognosis with caregivers and decide whether heroic measures are to be used. An elderly patient who is almost dying, there is no point in putting a ventilator to that patient. You have to decide that. Discuss with the family whether you should go for heroic measures, for example, ventilation or not. So, again, identify support system. That is, we discuss with family members and caregivers and identify causes of ICU admission, which may be the caregiver stress, may be the cause of the admission. So this happy elderly couple, they are free from all encumbrances, they are very happy. And lastly, there was a workshop in our country by the National Institute of Social Defense, Ministry of Social Justice Empowerment, Government of India, about 3 years back, 2.5 years back, and they laid down some minimum standards for the old age homes, what they should be. So thank you.
Any questions?
So I think the lecture was very boring. It is more or less not a very clinical oriented topic, non-clinical topic.
Any questions? No questions? Our sincere thanks to Dr. Kass.
No one understood probably. There are no questions.
Our next speaker will share his NGO experiences.
Yeah, he runs an NGO caring for geriatric patients. He will not talk on geriatric. The NGOs are very, very important in our country. Government has not awakened coverage. NGOs are taking a great part in geriatrics, starting from Welfare India, the Dignity Foundation, the Indian Association of Retired Persons, the Welfare Institute, and so on and so forth. Starting with Welfare India, of course. And now they are taking a great interest and they are giving the maximum care for geriatric patients. Till the government comes forward. So, sir.
First of all, I would like to express my gratitude and thanks to ISMOPH for giving this great opportunity, sharing this prestigious platform with you on behalf of my organization, Watchful Healing Touch. We are dealing with the elderly care support for last around 1 decade. It started in the year 2007 and now we are successfully running this institution, and We are the first organization in Eastern India who provides 24/7 elderly healthcare support. It is not our demand, this recognition is from the civil society, or that is the national based magazine, who declared that this NGO, that is our NGO, is the Kolkata's and Eastern India's first 24/7 elderly healthcare support. So it's my privilege also to share this platform with respected Sir Dr. Taposh Das and Dr. Anirban Sinha, and my thanks to Mr. Anirban Dolui and Dr. Rigu Basu for giving this prestigious opportunity to me and also to my organization. So NGO's role in geriatric care. First of all, already these are discussed by the eminent Dr. Dash, and just some brief point, some important data about elderly in India. More than 9 crores elderly people in India at present. More than 2 lakh centurion in India. And 48.2% elderly are female, out of which 58% are widows or divorced. 75% elderly are resided in rural part, and 1/3 belongs to widow poverty line. And around 50 lakhs elderly are alone. So what is the elderly care? It is a positive interventions for strengthening family and social support system for the older person in elderly care. There are basically three main components, that is the medical care, social care and security. Area of intervention by NGO. What are the sites, what are the fields where NGO can intervene? As because NGO is the very small things, very big NGOs are also there, but NGOs basically support the government sector or the public sector to implement their projects, implement their facilities, and these areas are the main area where NGO can play a very important role. That is the medical care first, the preventive services, curative services, social care, that is the care by family, care by caregivers, and the different sorts of rehabilitation, and obviously the security point of view, that is the law and legal point and programs by the government. The earlier conception of elderly care, that is the traditionally elderly cares are the responsibility of the family members. Now the family patterns are changes. Joint family, then extended family, now nuclear family. And in modern societies, there is a increased needs of government and role of NGOs. The main aim of the elderly care to strengthen their legitimate place in society and help older persons to live the last phase in their lives with purpose, dignity and peace. This is three important points. With purpose, that is productivity, dignity is very important, and lastly, that is the peace. So where the area of work by NGO, where NGO can plays very important role, at last to make productive use of older persons and to provide care to older persons in need. Sensitizing children and youth towards older persons, and I am really happy that many of you are the youth, belonging to the youth, and youth responsibility is very important responsibility to the elderly care. Reinforcing the Indian family tradition of providing special care and attention to older persons. Organizing older persons themselves, it is also very important, coherent self-help groups capable of articulating their rights and interests. Providing security, especially in health, emotional. Health is very important, and beside that, emotional security, that is the social and mental security, is another important part of this geriatric care, and obviously the economical aspect, and arranging training of all related persons with elderly care, and especially for caregivers. Caregivers are the very important part of the elderly care. As you know, that majority of the elderly people are depends on the caregivers or the attendants, and we are very much facing the problem that untrained attendants are now providing to the elderly care, and that reason there are several, I have seen the several cases where the elderly person dies due to the mismanagement by the attendant or the caregivers. So this is very important part where NGO can play a very important role by providing the training program to the elderly, the caregivers, especially related with the elderly care. And another important aspect is NGOs are the helping hand of government. Government, obviously there is a policy maker, the vast responsibilities are there, but beside that, government cannot reach the unreached part, the remote part. The NGOs have significant role as because they have the local contact. First, second, the local people rely on that because of their close proximity and easily approachable to the common people. So on this background, NGO can help the government also for effective implementation of government policies, especially in rural and unreached area, by monitoring and making awareness. Making awareness is also very important because like India, like our country, India, and the third world country, the rural area people or majority of people are unaware about their rights and laws, etc. So awareness making is very important aspect. If you create the awareness, then some problems are solved by only this creating the awareness among the elderly. So this is another role of NGO. And just briefly describe about my organization, how we are delivering the elderly care. 1st January 2007, we started our organization. Organization is started in the 1995, but we started this elderly care project, that is the Wajbu Healing Touch, touch that never hurts. Wajbu Healing Touch is a 24/7 emergency and preventive healthcare support for senior citizens. Our aim is to provide that the celebrate age with care and security. Not only on the health aspect, but on the recreational aspect also, to provide the productive life. The project consists of the preventive healthcare support by our dedicated doctors team, 24/7 emergency healthcare support by fully equipped medical team, and the emergency health desk 24/7. This is very much important. At the late night, when they are facing the problem, we will be there along with them to give the support. So this is very important. Not only in the urban area, also we are doing the responsibility in the rural part also for the underprivileged side, underprivileged people who are neglected by the family, by the society, just for the economical aspect and other social aspect. So this is also our responsibility. The geriatric care is not ends with the only healthcare support. It is related with the recreational activities also, to give them that feeling that needs of these elderly are now also there. So by that recreational support, by giving the enjoyment, by giving the cultural recreation, this is also the responsibility of the doctor. So we are also involved very actively in the social network, because social network side is also another side where we can spread the awareness about the elderly care. And you are very much aware about the social network, and so we are also active in that part. Our active Facebook group is there, that is concerned for elderly, where many elderly issues are discussed from the different parts of the world, not only the India, but different parts of the world. And there is a Facebook page also where the details are there, and 24/7 emergency healthcare support, that desk numbers are there. So this is very important aspect in the active social network. And another important aspect is the creating the awareness to the newspapers, to the news media, to the what is very easily reachable to the common people. So we are involved in that part also, that why the importance of geriatric care is there, what are the specialties of geriatric care, what are the legal aspects of geriatric care. We provide that sort of article in the newspaper, and by that we try to create the awareness among the common people. And that is also mentioned earlier that we are selected in the Inventive Indians, Great Stories of Change of Inventive Indians for this project 24/7 elderly healthcare project by the civil society, that is the Delhi-based paper magazine. And we are really feel the honor that along with the Devi Shetty's activities, we are also there in their selection. So respect seniors. It is the duty of all the society's people members, all the generations, not only by the seniors, not only by the physicians, not only by the family members, caregivers. It is the responsibility of the all to give the proper respect to the seniors. They need your recognition, not your compassion. Thank you for giving me this.
Thank you, sir, for your
An Indian overview. I'll be dealing with the social security and mainly on the available social security which is available in the Indian population and its implication, what may be the implications in the healthcare delivery and the healthcare of the geriatric persons. So how do we define social security? That is very important. So it is basically a support given to a person by the society or the state. Actually, our Indian concept of social security had a concept of seva. That in our traditional Indian society, we felt that helping an old age person, a geriatric person, is basically a form of service, a form of seva to the person. But social security has to be the responsibility for the state. Its implications in the families who are below poverty line and who are above poverty line are different. A family above poverty line may not be that affected by the social security, but a family below poverty line may be principally dependent on the social security. And basically we are concerning about social security in the geriatric population. So hoping many of them have retired, many of them have crossed their age of earning. So it is the duty of the state, it is the duty of the society not to force a person to work when he is not willing to. But it is very alarming as we find in studies that majority of the elderly poor in India have to work as long as they are in physical able. This is a study from Malam et al. He did in study 2012, multi-sector study. So this is the area. Now this is a public health conference. Now we are concerned about a geriatric person who, due to the lack of the social security, is forced to work in spite of not willing to, up till when he or she is physically able. Better to say apparently able. He might have needed rest, but he is forced to do work. Now, what may be the health implications in these situations? Now, what are the social security schemes that are really running in the country? If we focus on this area, first is the National Old Age Pension Scheme. The criteria is that the applicant should be 65 years or more, and he or she should have no regular means of subsistence from his or her source of income. Now there is another, is Annapurna scheme. Here, it is another form of social security where free food grains up to 10 kg per month is distributed through the public distribution system to the elderly poor. And what may be the other schemes? Other schemes are pension. Pension is a traditional form of security, income security. Any person who is in a government job is liable to pension. And our government has some schemes, National Pension Scheme, NPS, for the people who are working in the private sector. They can also have some sort of pension. But due to the fast globalization and our area, this security concept, the state responsibility, is really on the way. We are going for global competing market economy, where to competing costs, the market to compete itself, the company, where to cut down the cost. So the main area where it can cut down is the pension. Because if any area, other area, he or the company targets, it is really difficult. Because it would be affecting the productive age group. Suppose it curtails on the medical care, so the person who is working there, if falls sick, if with medical care would have been okay in 5 days, now becoming okay in 15 days. So it's a loss for the company. But pension is the area where the company can really cut down but still escape, because the persons affected are no longer in the company. And the persons who are there, they are not really very aware of the importance of the social security. So pension is a concept, but more and more privatization, more and more disinvestment, the main burden is basically coming on the pension. Now coming to the family pension. Yes, this is another our traditional statehood concept, that the family pension should be there. Now it is when a person who is having the pension dies, his wife will also be eligible for a portion of his pension. So this is a very good concept, that you are really securing not only the future of the working person, but also his dearest wife. Because it is very important when the person goes, the old man dies, who would be taking care of the old person? Now these are the concept of pension, where really it is becoming more and more questionable and challenging, as we are going to compete more and more for the competing market economy. Next is the income tax rebate. This is a thing where we are giving about 60 years, we are considering as the geriatric population. Yes, we are giving an income tax rebate to them, the government of India, so that they can, if they earn, they can really save more. So this is another thing. Now, the last one is the insurance scheme. There are few insurance schemes which are given by both the private sector and the government sector. LIC has few schemes, and our private sector, they have some schemes. But insurance schemes, so far have claimed, we have seen from the market reviews, do not give as security as the pension. Pension, we have many players in this insurance scheme, because this is a very trajectory when the person becomes aware that he or she must have some security, and it is on the wane, our pension scheme is on the wane, he or she will search for insurance scheme. But the private players find this very lucrative, but still the paying off is not always as expected. Now, what are the major social security schemes in elderly in West Bengal? We have been mainly focusing on the Indian scenario. Earlier I was talking about the scenario of India. Now coming to the scenario of West Bengal. When we talk of income security, our West Bengal government, this is the basic modification of the National Old Age Pension Scheme, Indira Gandhi National Old Age Pension Scheme. Here we are giving rupees 400 for people in the age group of 60 to 79 years and rupees 1000 for people 80 years and above. In the National Old Age Pension Scheme, this money differentiation and the age differentiation is not there. Under Puna scheme is there and the Old Age Pension Scheme is also there. Now, another part is that when we are dealing with the security part, I have been dealing with the social security, I have been coming to the financial security, and next part is the healthcare security. Because we have to secure a person in these three areas. Because healthcare is, as we find in various studies, that are also quoted by our famous economist, Professor Amartya Sen, it is the leading cause of bringing a person from the APL to the BPL. So what is the government doing for giving a healthcare security? We have a national program for the healthcare for the elderly, launched in 2007 with subsequent modification. Yes, it says of a tier model for geriatric healthcare. We have our sub-centers, our primary health centers, our district hospitals, our medical colleges. In Apex referral, we have in All India Institute of Medical Sciences and National Institute of Aging in Chennai. And in Eastern India, we have in Medical College also our referral center. So this is, we have spoken of that there should be at least a dedicated geriatric outdoors. There should be at least opportunistic of screening them and designated beds for the geriatric people. But still, our reach of the program and its implementation in all levels had not that been really evident. And what may be the other social security schemes for the elderly in West Bengal? They are the residential and the daycare services. Here we have the concept of old age home, where the elderly are kept in the old age homes. And another is the daycare center, where the elderly go and come back in the afternoon. We have the elderly self-help group, and Pranam is an initiative launched by the Calcutta Police. It is a 24-hour helpline for the elderly. And my previous speaker have retained the role of NGOs. We are really supporting that the NGOs and CBOs come up in the area of geriatric healthcare. Now, this has been our things which really are. But these are the areas where we have to really focus that are they really doing good. And if we see in the reverse way, the opposite side of the coin, that what are the areas to be done. This is a study, a multi-centric study done on the 4 regions, East, West, North and South India. But they have found of West Bengal that they have tried to find that the elderly aware of the social security schemes according to sex and non-BPL, BPL household category. You see, we have divided. This one is the BPL households and this one is the APL households. So we are noting a difference in the awareness about the social security. Now, how much we have really extended? I am focusing on West Bengal because it is easy to focus on a single state to find out the coverage. This is data we have obtained from our government, that what is the coverage of our old age schemes. You see the last one, Annapurna scheme, the beneficiary in 2011-12 was 56,099. In 2012-13 it was 65,068. So you see, we are really not able to cover. We are really not able to cover really the large chunk of the population. This is the Indira Gandhi National Widow Pension Scheme. This is another scheme. Now, if we find the coverage, it is little higher. It is 3,89,432, and in 2012-13 it was 9,51,770. So another thing that has to be really focused on these areas, that our government, according to the government rule, if any elderly is availing any one of the 4 or 5 schemes available, he becomes not ineligible to obtain the other. Suppose old woman is getting Indira Gandhi National Women, Indira Gandhi National Widow Pension Scheme. So our government will not try to enlist him in Indira Gandhi National Old Age Pension Scheme, because the government motive is that to reach to the maximum. So the government logic is that when we are giving some sort of security in one form, why should we give another? But this is the area, because he might be eligible, but the amount is so much less that really it is difficult for him or her to survive, that forces them to work. And this is the area I wanted to really cover. This is the situation. This is the background. Let's say we have been in the morning, we have been talking on cognitive dysfunction, we have been talking on aging, we are talking on dementia, so musculoskeletal disorder. So now if we go to the dire reality, that we are basically dealing with the geriatric area, but really where they are aged, they need rest, and they are not able to give them social security. So definitely these implications would be different for an individual who is given adequate social security. Now this is the elderly utilizing national social security schemes according to wealth and caste and tribe, West Bengal. We are really seeing that this is the wealth quintile and this is the caste and tribe. So we are noting there is a difference in utilization when you are really considering the caste and tribe. So when we are thinking of a model, a delivery model of really helping the geriatric population, we have to take care of this issue. And also the wealth quintile, as expected in the lowest wealth quintile, it is the list. It is as expected also. But still, this is the area we really want to reach, that we have to provide social security to the persons who are really in need. Now this apart from, we have been dealing with the social security schemes. Now, what may be the implications? We have found in studies that how to measure the implication of the social security of the geriatric population is the quality of life. It is a very good measure how the elderly is there, how the elderly feels, and whether his quality of life differs